A very good evening to all of you. On behalf of the Sri Lanka College of Psychiatrists and the Trincomalee Clinical Society, I would like to warmly welcome you all to the Regional Psychiatric Sessions 2021 organized by the Sri Lanka College of Psychiatrists in collaboration with the Trincomalee Clinical Society. I am sure many of you are looking forward to visit the Trincomalee town in person and attend the sessions at Trincomalee by Cinnamon. Unfortunately, we had to cancel them at the last minute due to the worsening of the COVID situation in the country. Nevertheless, we are still privileged enough to gather along this digital platform and proceed with this important educational program in the calendar of the College of Psychiatrists. Let me first introduce myself. I am Dr. Malisha Rodrigo, working at DGH Trincomalee.
Good evening. I am Dr. Krishan Balasundaram from DGH Trincomalee. Dr. Malisha and I will be comparing the sessions. Let me give a brief introduction of the event. There will be two symposia. The first symposium is on addiction, and the second is on interplay between psychiatry and medicine. Let me remind you that you are free to post your queries in the chat box, and those questions can be discussed at the end of each discussion. Also, please note that this webinar will be recorded and uploaded to the Sri Lanka College of Psychiatrists website in few days.
To begin the sessions, it's my pleasure to cordially invite the President of the Sri Lanka College of Psychiatrists, Consultant Psychiatrist, Dr. Gihan Abewardena, to deliver the welcome speech.
Thank you. Good evening, Council and members of the Sri Lanka College of Psychiatrists, Dr. Uday Samarjeeva, the President, and the members of the Clinical Society of Trincomalee, resource persons of the conference, the 5 consultant psychiatrists, Dr. Anil Abesinghe, Dr. Mahesh Rajasurya, Dr. Kapila Ranasinghe, Dr. Sumudu Godavita, Dr. Samira Dasanayaka, and Dr. Dulmini Veeratunga, the consultant neurologist, Dr. Kanchana Ramanayaka, consultant radiologist, and Dr. Jevon Yudhishthran, the consultant physician. The chairpersons, Dr. Gadambanathan, Professor Thilini Rajapaksha, and Dr. Chamara Vijayasinghe. It is with great pleasure that I extend a warm welcome to all of you to the inaugural regional conference of the Sri Lanka College of Psychiatrists in collaboration with the Clinical Society of Trincomalee. As told earlier, this was planned to be held at the Trincomalee by Cinnamon Hotel on the 19th of December 2020. And this has been postponed 4 times already. And it was subsequently decided by the college that we will have it as a webinar via Zoom due to the travel restrictions and the raging corona pandemic. The primary aim of conducting regional conferences by our college is for the membership to acknowledge and appreciate the services of the peripheral psychiatrist with minimal resources, to develop networking between the senior and the junior members, to update our knowledge on the recent advances of psychiatry, and also to share and gain knowledge from our colleagues in specialties related to psychiatry. And we were all eagerly looking forward to and having elaborate plans of having an outdoor conference with a moonlit sky facing the sandy beaches of Trincomalee. But let's look at the positive side of things. Now we are able to have a wider audience who can benefit from the deliberations of this meeting at the comfort of their homes and be safe from the pandemic. We all hope to meet up in person, physically, in the future at our subsequent regional meetings, hopefully in Anuradhapura, Batticaloa, and so on. The first symposium, as already we got to know, it's about why people get addicted and the management of addiction disorders. And then there'll be a discussion by the regional psychiatrist about how they face the obstacles and with minimal resources overcame the problems of establishing psychiatric services in remote areas like Trincomalee. And then it's the second symposium about the interplay between medicine and psychiatry. So I'm ever so grateful to the 3 senior psychiatrists for updating us on the recent advances on addiction psychiatry, as well as the members of the Clinical Society of Trincomalee for enlightening us on the psychiatric manifestations of physical disorders. And let me, on behalf of the Sri Lanka College of Psychiatrists, express a heartfelt gratitude to Dr. Sumudhu Godavita and her team in Trincomalee for going out of her way and taking a lot of trouble in organizing this conference in a meticulous way. And also the president and the members of the Clinical Society of Trincomalee for wholeheartedly agreeing with us and collaborating with our college in making our inaugural meeting a reality. Thank you once again for your participation and kind cooperation. Hope all of you will enjoy the session today and benefit from the timely discussions we have lined up for you today. Thank you.
Many thanks to sir. Our first symposium is on addictions. I am pleased to invite consultant psychiatrist Professor Thirani Rajapaksha and consultant psychiatrist Dr. Kadavanathan Thanabalasingham to chair the sessions.
Thank you for that introduction. So it is a pleasure and honor to be able to welcome our first speaker for the day today. He's Dr. Ranil Abesinghe, who is a very well-known senior consultant psychiatrist. And also he was the head of the Department of Psychiatry, Faculty of Medicine, Peradeniya, for many years until he retired. Many of us here will also remember him, his clinical teaching and training in psychiatry, which I think many of us still benefit from today. So given that, I very warmly welcome Dr. Abesinghe and invite him to update us on the neurobiology of addictions. Over to you, sir.
Yeah. Hello? Can you hear me?
Yes, sir, we can hear you well. We are
Can you
seeing
see my? I'm trying to
not
get my.
the slides, not the
No.
slides. We are seeing the Zoom.
Let me open them.
That's right, sir. Second one.
Right.
Brilliant.
Okay. All right.
So you can
Yes.
also magnify it.
Yeah. This one.
That's right. Awesome.
Right. Now you can see it.
Can
Yes?
see, can hear, sir.
Yeah. Good. Good afternoon, everybody. Thank you, Thirani, for these nice words of introduction. Thank you, Gihan, for inviting me to give this, to speak at this webinar, which is not a very, which is a new experience for me. I've been more used to getting on the stage and speaking. As you can see, I have, there's a little subtitle that is Journey from Impulsivity to Compulsivity. That is, how does a person or an animal move from an impulsive use to compulsive use of substance use or drugs of addiction. Right. So here, let me start with a few definitions. As what you can see is that there are 3 tiers of use of substances. That is, so let's stick to heroin here, or that's our main focus. So we have the risky substance use, that's the impulsive use. Then there's the substance use disorder as defined in DSM-5, and then there's the hard addiction. Now, what DSM-5 has done is that they have gone out of addiction and included much of this risky substance use as well, that is abuse. And so under the title substance use disorder. So that's a new definition of that DSM-5 has come up with. So I'm sure ICD-11 will follow suit as well. So that in addition to hard addiction, they have also included these abuses. So So that's the classification. And then if you look at the DSM-5 classification, it has usual elements of tolerance, withdrawal symptoms, craving, the everything that you know of, and I don't need to repeat those things here. Now, I found this. Now let's about impulsive use to compulsive abuse. Now, how common does it happen? Now, there is this table which is interesting, I thought. That is, here we have percentage of those who get addicted with first exposure. There's just one use, and surprisingly, it is tobacco with the nicotine use with one first use of cigarettes. 32%, that 1/3 of them seem to become addicted. Heroin, it is little less, 1 in 4, as you can see. So those first-time users, 3 out of 4 can get away. Cocaine, it's 1 in 5. With alcohol, is about 1 in 7. Stimulants is 1 in 10. Cannabis is much less, again 1 in 10 or so. So that's something worth bearing in mind. That is, nicotine is more addictive than heroin. So in describing the neurobiology of that is the brain changes in addiction, those who the neuroscientists have had problems because most of the work they have done is in rats. Right? So there is the classification that they developed in the rats. That is, the first part is the drug self-administration, the conditioning, brain stimulation, increasing reward threshold. Then second part component is anxiety-like response, withdrawal-induced drug administration. Then third component means the drug-induced reinstatement of all 3 kinds. Now, fortunately for the neuroscientists, these stages that the psychiatrists develop also correspond. There is the intoxication part, then there is the second part of the withdrawal, negative effect, then we have the preoccupation, anticipation. So that is where most of these patients, there's reinstatement. So there's this beautiful correspondence of these 3 stages between humans as well as animals, right? So it seems as if that, well, whether it's a rat brain or a human brain, they go through these stages, and that there are these 3 circuits. There are these circuits which become active, right? So let's see what happens. Now, these are the important neurotransmitters that are active in both humans and rats: dopamine, endocannabinoids, GABA, opioid peptides. There are a few others which I'll mention as we go. So this is the most commonly known circuit, which I think all trainees study. That is that's one of stimulation, one of rewarding experience that you get. That is, you have the VTA, ventral tegmental area. Then there's the mesolimbic pathway of dopamine going on to the nucleus accumbens, which is also called the ventral striatum, and then going up to the prefrontal cortex. So this pathway is present in all addictions, which includes, for example, gambling, whether it is pornographic addiction, whether it is heroin, cannabis, cocaine, and also it includes our president's addiction to the leopards, as you can see in the background behind him, right? So this pathway is one of the most important pathways, and that's where one of the best known pathways. Here what happens is that dopamine seems to stimulate the nucleus accumbens, and then it creates intense pleasure, and then repetitive use, which accompanies that. Now, in the case of heroin, it is not so much dopamine which is active, but mostly the opioid peptides that are within the brain, right? So that seems to be the only difference, but dopamine is also active in the case of heroin. Now, let's move on to the next two stages. Now, in this diagram, what we have done is set the color indicates the stage, right? If you look at the blue color, blue is the rewarding part, the first part, first circuit that we know. As you can see, the thalamus comes into this, global pallidus comes into it, and then of course the ventral striatum or the nucleus accumbens. So the VTA is not shown here. So here is the blue part that is essentially the rewarding experience, right? So the blue is rewarding. The next pathway that gets active along with this and in between, there's a second circuit. That is the one that is red, which you can see. That is, as we can see, the amygdala. And the amygdala, and then a certain part of ventral striatum, and then the basal nucleus of the stria terminalis. These are some of the pathways which come in, and also part of hippocampus, which essentially are circuits or parts that are concerned with anxiety and stress, because we all know amygdala is concerned with anxiety, right? And hippocampus with memory. So these are components that set off anxiety and stress reactions. And here the neurotransmitters are also different. Here there is much noradrenergic activity, as well as another opioid, that is dynamorphin, right? And then CRF, that is the corticotropin releasing factor. So as you know, corticosteroids are stress related. So as you can see, there's a second circuit that is at work, and that's the one that corresponds to the second stage that we were talking about, withdrawal and the negative effect. So the negative effect is created in these circuits. Then we have a third circuit, which is which you can see is seen in green. That is the orbitofrontal cortex, then the anterior cingulate gyrus, and again a large part of the hippocampus. So these circuits are essentially this is what happens to these circuits. That is, as long as this circuit is active, these circuits, because imagine you start taking heroin and it gives you intense pleasure. Obviously, prefrontal cortex, which is doing something else, which is trying to control these impulses, is basically shuts down. So these become less active. They are, in fact, in human beings, it has been shown that the D2 receptor activity is much less in heroin abusers in the prefrontal cortex, right? And also in the anterior cingulate cortex. So this is what creates a craving, right? And that reinstatement, that I talked about, preoccupation, anticipation, and this drug-induced stress. So that the reinstatement comes from these more, shall we say, the superior part cortex, that is the prefrontal cortex and the anterior cingulate cortex. So this is essentially what neuroscientists have found, and that this seems to be the case both in rats and in animals. This is another representation of the same thing which I talked about. And this is another beautiful PET scan to show the normal brain, healthy brain, as well as the addicted brain. What you can see is there is this reduced activity of the prefrontal cortex in these are human brains, right? And just to compare what happens in the healthy heart and infarcted heart. So you can clearly see the reduced activity in the heart, the same thing that you see in the addicted brain. So what are the factors that influence use disorder? One is heritability. Heritability seems to be everywhere, whether it's alcohol, heroin, or even cocaine. That is 50 to 60% of that seems to be due to heritability. And the second one is adolescent use. If patients start using during the adolescence, they are much more likely to continue to use and become addicted. And the third one that we often don't talk about is ADHD, the role of ADHD and conduct disorder. I'll briefly talk about that a little later. And of course, the drug availability and the environment, the drug culture. If there is a culture which promotes heroin use or cocaine use, that's what is much more likely to influence a person to use it. So let's look at it from the other side. That is the psychiatric aspects of heroin dependence. So this is one of the most important factors that I think we have to remember as psychiatrists, that the problem of ADHD in childhood and adult ADHD, 25%. Right? So a child with ADHD has a high risk of abuse of substances later. And then, as you can see, it is 1/3 of one third of them have had childhood ADHD, and 1/4 have adult ADHD amongst the abusers. And then the conduct disorder. If you have ADHD and conduct disorder, there is a much higher chance that the person would be abusing substances. So that's something that is, I think, important for all of us to keep in mind. The propensity for abuse in these children. Then the depression is 25%. This, of course, can be a two-way process. Say substances can cause depression as heroin can cause, and also depression can cause heroin or substance use. Then the other important element is PTSD. So one good study shows that PTSD is present in 41% and trauma exposure in 92%. So that's a high percentage, right? And then we have the attempted suicide, 34%. It's something that we should always look for in patients who attempt suicide. And then suicide itself, that is, the suicide is present in is 16.2 times the standard mortality rate in a given society. So suicide risk is very high in substance abuse, particularly heroin abuse. I'm referring to heroin abuse, here in these instances. The other important thing that we need to bear in mind, of course, not opioid-induced hyperalgesia. There is this interesting study when rats were given one injection of heroin, they developed lifelong hyperalgesia. They reacted very badly to any minor pain. So, and that they did anything to avoid. There are a series of studies which you can see, which clearly show that hyperalgesia is a major problem in opioid dependence. Right. The other important problem is some of the physical risks that inhalers have. That is something like 40% developed, as you can see, lung complications, and 15% have developed asthma. Then toxic leukoencephalopathy, which neurologists have described. Then, of course, the risk to others, that is, offending increases by 3 to 4 times. Yeah. Sorry, I can't show that. This is about a 3-wheeler driver who was involved in a major accident that killed 3 or 4 people, and that he was abusing heroin. One of the passengers who died was a lady who was a deputy director in Central Bank. Right. Yeah. This is another thing that has been looked at, whether there's a difference between smoking and injecting heroin. When survey after survey has clearly shown that there's no difference between the severity in people who inhale or inject. Right. The the National Survey on Drugs Use and Health in US. US was the most important survey, which clearly showed that there is no difference between inhalers and injectors. But inhalers were less likely to get treatment. That is something that that has been shown. Okay, so all this time we talked about the neurobiology and the severity of heroin abuse and the difficulties it causes, right? So I'll have to end this presentation with this very interesting study, that is the story of Vietnam vets, because in the from 1960s onwards, the US they sent the young men to Vietnam to fight a war which they didn't believe in, most of them, and then the American media, they reported something like a very high prevalence of heroin abuse amongst these soldiers who are fighting in Vietnam. So one study showed that something like 34% of the American GIs used heroin while they were in Vietnam fighting the war, and most of the heroin they used was some very pure form, something like 90% pure, right? And 20% became dependent while they were in Vietnam. So this raised a major controversy, and that there was major alarm raised by media as well as the President Nixon at the time, saying that we will be overrun with these addicted heroin abusers coming back from Vietnam very soon. So there was a real fear, and so because of that, they asked a very famous person called Lee Robbins, right? If there's child psychiatrist listening, he or she will quickly, he will know who this Lee Robbins is, because she is the one who described this issue of conduct disorder turning into antisocial personality later in a major study. So she was asked to study this, and what she found was that only 1% of these people who came back from Vietnam continued the habit, right? And this was totally unexpected. And so the media doubted it, other scientists doubted the methodology. So they all went into it and they looked at the methodology, found that there was nothing wrong. Yes, that is true. Only 1% continued. And but interestingly, the former heroin users are now heavy alcohol abusers, right? So this was a major finding in the United States. And what are the likely reasons? Say, how can we explain this? That if you go back to the previous slide, you remember that we said the reinstatement can come from the availability of drugs. It can come from stress. It can come from the cue induced. That is the place where they had this heroin, or the friends that they met, whatever, even the sight of a syringe. Now, so the only explanation we can give is that even though 20% were dependent, but when they returned to United States, drugs were hard to come by, and that it was no longer pure. It's something like more than 60% of it was adulterated. Then there were those old cues were no longer there, like the sound of a gun or the friends that they were using it with. Then also the stress was not there. They came back and they had sex with their girlfriends and got married and raised families and found jobs. So that's the social aspect of it, which seemed to have changed this scenario. So there is the neurobiology of it. There's the sociology, and I will leave you there with that observation. Thank you for listening.
Thank you very much, Dr. Abhay Singh for that really informative presentation and thought-provoking. I'm sure there may be questions. I mean, we have a little time. We can open the floor for questions. You can just ask the question or put it in the chat. So I might start with a question while they are thinking of questions.
Yeah.
So overall, with regard to addiction, are you on the side of nature or nurture, sir? Because I saw that it's both. So which do you?
I think both are probably equally active, because if you take, for example, alcohol is the best example, right? That I mean, we know that genetics play a major role, something like 60% in alcohol. But if you study the females in Sri Lanka,
exactly,
alcohol use and abuse is very low. I mean, it's a country with one of the lowest alcohol abuse rates amongst females. So that is clearly the culture. I mean, because it can't be the genetics, because they are equally likely to have the same genes. So that is there, yeah. So I would think it's 50-50. Right?
50-50, sir. Not more genetic. No.
It doesn't, because this is not a disorder, something like Huntington's disease, which is 100% genetic. Here, the availability matters. The drug culture seems to matter. The acceptability of the use of heroin or the cocaine or the alcohol. I mean, as you can see in say in this finding that the former heroin users from Vietnam, they were now using alcohol, because heroin was acceptable amongst the GIs in Vietnam. And whenever they went to Thailand, they had a particular name, R&R, I think they call it, rest and recreation. They were using heroin, and Thailand became rich with this R&R business. And of course, women, that was they were very sort of part of that culture. Whereas when they came back to United States, heroin was not part of the culture. Right? It was very much looked down upon, and there was a major stigma. But alcohol is a part of that culture. So here they became heavy alcohol users. So this propensity for use substance, I think, is genetic and it is there. But how it manifests, probably it depends a lot on the society and the particular culture that they live.
Okay, so it could manifest as photography, for example, leopards.
Leopards, yes, and Wilpattu, right? You know, addiction to Wilpattu, probably.
Yes.
So I'm Shama here, sir.
Hello, Shama.
Yeah.
I can see you.
I have a question, sir, in the sense like I was thinking whether like now in young age they tend to take more heroin than alcohol because the fact that probably the reward pathways and other things, and when they become mature, they might be using alcohol. Is there an age like have they anybody? How the
that been shown. Thank you, Shama, for reminding me. Heroin use tends to one of the natural ways for heroin abuse to go away is maturing. That is, when they reach the age of something like 40, there seems to be a reduction by about 20 to 30%. They give up heroin, right? And I'm not sure that they start drinking alcohol. They may well be, right? But as we can see here, so certainly there's an age effect. And even here in this country, we see that, don't we? That is, most of the heroin users are in their late teen years or in their 20s. And many of them seek treatment when they hit 30s and early 30s. So, and the and the response to treatment is also better with the older groups. So yeah, definitely it's been shown. The maturing rate is something like between 20 and 30. That's been shown.
So there is another question from the audience in the chat, I think from Dr. Vikrama. The question is the neurobiology of addiction to internet and games the same as this?
Yeah, apparently the basic mechanism which I described in the first few slides on the neurobiology is supposed to be the same. And this is why if you use naltrexone in gambling, it works. I mean, clearly, there is a study, there is work to show that they improve for gamblers. So try that. If you see gamblers, right? See gambling. I'm not too sure about internet addiction. It may well be worth trying. The internet addiction too. Because the pathway is the same. You know that as I showed you the very first slide in the let me try and show you that. This very first one. This is universal for all forms of addictions. That is this one. No, sorry. This one, right? So there is no difference that whether it's a smoking or alcohol or heroin or gambling, it's the same. And also pornography addiction. That's another one that now they describe because one of the major causes of sexual disorders in young people is pornographic addiction.
Thank you, sir. Are there any other questions from anyone? I think we're also having a discussion at the end. So if there are any more questions, we could come in then. So thank you once again, Dr. Aviasinger. Really appreciate that interesting presentation. Thank you, sir. I will now hand over to Dr. Kadambanathan to introduce our next speaker of this symposium.
Thank you, Tilini. So next speaker is Dr. Mahesh Rajasuriya. He's a senior lecturer in psychiatry in University of Colombo and also honorary consultant psychiatrist attached to National Hospital of Sri Lanka. And he has many special interests, and among the important thing is one is addiction psychiatry, the other one psychotherapy, and also the community psychiatry. And he has been working in the field of addiction psychiatry, and he is a pioneer in fighting against the tobacco addiction. And he's currently the director of CCT, one of the center fighting against tobacco addiction. And he has written many books as well as journals, articles. And he's not new to Eastern Province. I think about a decade ago, he has been working, he had worked in District General Hospital, Ampara. And he has been the pioneer of community mental health services and has established a forum, Foundation of Mental Health. So over to you, Mahesh, to enlighten us on this addiction, how much is in Sri Lanka and what we can do. Over to you, Mahesh.
Thank you, Badu. Thank you. I brought back sweet memories from Ampara. Thank you very much. And thank you, President and the Council of the Sri Lanka College of Psychiatrists for organizing this in the first place. And second, inviting me to speak, and the Clinical Society Trincomalee. Yes, so let's get on with the slides straight away. Okay, so my topic is extent of substance use in Sri Lanka and psychological management of addictions. So this is an overview of what I'm going to speak about. It's actually two components combined together in this topic. The first one is the extent of substance use in Sri Lanka. We'll talk about the indicators and some data. Then the next part is about the psychological management of addictions, where we'll talk about the treatment goals, the biopsychosocial management, and so on and so forth, which for which the foundation is nicely laid by our teacher, eminent psychiatrist, Dr. Manila Besigman. Thank you, sir, for that. And I don't have any interest to declare except that this CCT that was mentioned is funded by the World Health Organization and the International Union Against Tuberculosis and Lung Disease. Okay, so let's first talk about the extent of substance use in Sri Lanka, indicators of alcohol use. Right, so I think I'm trying to pitch this for the practicing and experienced psychiatrists as well as for the training. So if you look at according to your audience, according to the person or the section of the society that you are trying to measure, your indicators change. That's the main message. You can't use an idea of alcohol or substance use in all aspects. So for an example, if you take the entire country, we talk about things like per capita alcohol use. So I'm using alcohol here. Otherwise, comparing so many substances as indicators will be complex. So if you take alcohol, it's the per capita alcohol use that gives a good idea about the alcohol consumption in the whole country, which is pure liters of alcohol used by a person. But you are taking only the population of 15 and above. And then you can also look at sales figures, tax incomes, and so on, to have an idea about the extent of the alcohol use or any other substance use in the entire country, if it's the legal trade. And then the prevalence, how many alcohol users are there? And we can also look at how many smokers are there, and so on and so forth. So that's the entire country. And if you look at a smaller population, so you are the MOH, or you are the MOMH, so you're looking at regional, you're at one, MOH area, or you're looking at a particular village. There are 1,500 people or whatever. So then you can, if available, you can look at sales figures for that district or for that MOH area if available. Or you can improvise indicators like visible alcohol use, how many alcohol points there are in this village, how many illicit alcohol sale points there are in this village, and you can objectify them as needed if it's a research and so on. Again, you can look at prevalence. If you're looking at a single person, then you can measure quantity as well as quality and the overall alcohol or whatever substance use. So quantity, you can in alcohol you can say this many units. You know how to calculate the number of units a person uses. So this many units per week, this many units per month. So somebody who uses 30 units a week is at a having high impact than somebody who uses 7 units a week. And then the quality, of the way the alcohol is used or any other substance, then you can talk about use patterns. This person takes alcohol every day, starting from morning, versus another person who uses alcohol once or twice a week. So that's, you're describing the use pattern. And the duration of that current pattern is also very important, in addition to the entire duration of the substance use. This becomes more important when you're presenting a history. Overall, we can look at clinical diagnosis, we are giving a diagnosis. Is it, we are still using ICD-10, so is it alcohol dependence or alcohol harmful use, or heroin dependence or harmful use? And then you can use, always clinical diagnosis trumps any other indicators of overall alcohol use. But second best, you can use tools like audit, CAGE, TLFB, that's the timeline follow back method, which measures the amount of alcohol used in the last month. Okay, so these are few figures, data, information about the extent of substance use in Sri Lanka. So let's first look at alcohol. So this is from the WHO, the Global Alcohol Report. So the data on Sri Lanka, you can have a quick look at this, but I will go to the table in the bottom. That gives us the data about the per capita, that is 15 plus consumption of alcohol in liters of pure alcohol. So if you go to the row before the last, total males, females. So in 2016, the total number of liters of pure alcohol used by one person, 15 plus, is 7.7 in males and 1.2 in females. So you have to add them up and divide them by 2 to look at the total, which is in the row about 4.3. There are a few disputes about the measurement of this. Certain discussions are going on. Some forces feel that these are too high. Anyway, this is slightly higher than the, or slightly lower than the Southeast Asia regional average, but it is much lower than what you find in Europe and in other Western countries. And this is from the trend survey of 2020 from done by Addict Sri Lanka. So there you can see that it's a measure of prevalence. So there is 50% of the population is lifetime abstainers in Sri Lanka. 22% of them are current users. That means they have used in the last 30 days, and 20% of them have used alcohol, but they have not used alcohol in the last 30 days. So that also gives another picture of the extent of alcohol use in Sri Lanka. So this is, as I showed you before, this is another way of indicating, or another set of indicators of alcohol use or any other substance use. These are the income, and the production figures, absolute liters produced and sold by these companies, as well as the tax income. These very important in cigarettes, because it's there are not too many indicators. So the number of sticks produced, because you can find it in the annual report of Ceylon Tobacco Company, and that's basically mostly the entire tobacco consumption or cigarette consumption in the country. Now this is tobacco now. So this is from the WHO stepwise approach for surveillance steps survey. So it shows that the prevalence of smoking use among males was 29.1%, and that among females it was 0.4%. As Dr. Abhijit mentioned earlier, just like alcohol, the tobacco use is way below the levels found in many other countries in Sri Lanka among women. Then you have to add them both together and divide by 2. Then you get the national tobacco use prevalence, which is 15% of adults in Sri Lanka. And the smokeless tobacco users, the prevalence come close. However, the latest evidence, which is not published yet from WHO, indicates that the tobacco prevalence in Sri Lanka has gone down below 10%. So this is 15%, but in 2006, so it has apparently gone below 10%, which is a great achievement for a country, for any country, and especially for Sri Lanka. And again, the trend survey from Addict says that it's going down. Extent of other drug use. So this is from the Handbook of Drug Abuse information from the NDDCB. Prevalence of cannabis prevalence of cannabis use is 1.9% of the total population of about 14 years, that is 15 plus. Estimated number of users is about 300,000. These are estimates, so maximum maybe 600,000. I'm not sure whether they have captured these 2020, but it may be on the rise because of this immensely funded campaign to popularize cannabis in Sri Lanka currently. Prevalence of heroin users is 0.6%, way below than cannabis prevalence. It's about 100,000 people or less in the country. And methamphetamine and cocaine users are much lower the number than these figures. So compared to alcohol and tobacco, you can see that still, perhaps cannabis is a sizable problem, but others are still not numbers-wise at all comparable to alcohol and tobacco by any measure. Okay, so that's about the extent of the substance use in Sri Lanka. So you can see that there's no one single indicator which gives okay, this is it, and that's that. So it's you need to get an idea of the overall picture of the extent of substance use in a country as well as in Sri Lanka. Okay, so let's move on to the next component of my presentation, psychological management of addiction. There I would talk about these bullet points. Right. Now, what we see in standard psychiatry that we practice, we learn, we teach, in addictions or in addiction psychiatry or in management of addiction, patients with addictions, the use is in the center, the use of the substance, tobacco, alcohol, or whatever. So our main focus is in stopping the use in this person or reducing or stopping. Our focus is use. That's what we keep talking about, but that's what we do research on. Can disulfiram stop alcohol use or reduce? Right? It will stop rather than reduce. Can naltrexone reduce or stop? Can motivation enhancement reduce alcohol or tobacco use or whatever? So use is at the center of what the way we look at it, the way we try to help people, and we are trying to achieve abstinence or cut down. However, when you assess a person, when you do a proper assessment of a person with a substance use issue, you found out there are so many issues to be managed. If you look at the person rather than the disorder, you will find in this hypothetical person, there's alcohol dependence, there's harmful use of tobacco, there's depression, there's grief, there's marital discord, and domestic violence, poorly controlled diabetes. So there are so many issues clinically relevant that the psychiatric team has to now sit and develop a management plan for. So that is what we do in our clinical practice, the biopsychosocial management. So to address all of these issues, at least some of these issues, you need a comprehensive approach, a holistic approach, which is biological, psychological, and social, and which is, the foundation, again, I'm emphasizing, was nicely laid by Dr. Abhay Singhan. So this is, although this part of the speech is titled psychological management, I would rename it as biopsychosocial management. And since I have been asked to talk about psychological components, I will take that as the main focus, but then I would call them psychological treatments rather than psychological management. The management is biopsychosocial. Even if you claim you are a biological psychiatrist and you are mainly focusing on medications, you are still using the biopsychosocial approach in your management. Right, let's talk about psychological treatments. I'm mainly trying to look at the principles and the way they are relevant in our day-to-day clinical practice. So there are many psychological treatments that have been found to be effective and that are being used in addiction psychiatry. For an example, CBT. So there's CBT for alcohol, CBT for cocaine, and so on and so forth. So I'm not going to talk about in great detail. So you know the principles of CBT, and you are trying to use the relevant beliefs, behaviors in order to modify the emotions which may predispose to issues seen in substance use. Again, CBT focused on reducing the use or achieving abstinence from the substance. Then you have motivation enhancement. I'm not going to talk about the principle of them. So it's about behavior change. So how motivation enhancement principles can be used, or you can use classic motivational interweaving to help the person to move forward with behavior change. Psychoeducation, although underrated and not much research done, is what we use all the time. I mean, practically, that's what happens. We use psychoeducation in various forms. However, our psychoeducation is based on principles of CBT, principles of motivation enhancement. It's not just we are, speaking out words. We are trying to incorporate these principles into the psychoeducation we are giving our patients. And then the brief interventions. It's kind of psychoeducation, but I wanted to mention it here because, for an example, if the general practitioner asks from every patient that they see, do you smoke? Have you thought of giving it up? It has been shown that 10% of them quit smoking. So it's a very, very brief intervention. It will take 30 seconds. And then you can go up to, the 45-minute WHO recommended brief intervention package and so on. So these brief interventions, brief in the sense, it's true literal sense, do help, are effective. And then the 12 steps facilitation, we know that there's enough and more evidence that it works, at least to some degree. And this, the emerging more modern psychosocial or psychological treatments, social network and environment-based therapies, where you address the belief system, the culture Dr. Abhisingh referred to, which facilitate substance use in the patient as well as in the patient's social network and the environment. And the evidence is really promising, for this more than any of the above listed. The evidence is really promising for these types of newer, not so new, but next generation psychological treatments, including community reinforcement approach, where the person is more accepted in his community, in his family circle, when he's staying away from substance use, changing his behavior or her behavior. So that's community reinforcement approach. So these last two have a lot of powerful evidence. And last, I want to mention a few words about the combination of SNEBT, CRA, and some more components. I will come to that in a minute. Slide. So that is what I trialed in my PhD study, my MPhil study, which was is being converted to a PhD study right now. It's called the Efficacy of 2 Alcohol Treatment Strategies in Sri Lanka, a randomized clinical trial. So in that, I checked the effectiveness. It's more than efficacy, it's the effectiveness of modified disulfiram therapy and multimodal psychosocial therapy, which is the one that I'm going to compared to the usual treatment package, the green one on the bottom, in improving treatment outcomes. So it's not only alcohol consumption, it's alcohol consumption, related attitudes and behaviors, and quality of life. So those are the things that I looked at for patients with alcohol use disorders. Right. So that's the study was about. I'm not going to present the results of the study here, but I'm going to speak in my last few minutes about this multimodal psychosocial therapy, which I trialed or tested against the usual treatment package in this RCT. So what is meant by multimodal psychosocial therapy is that it has incorporated these effective social network and environment-based therapy principles and the community reinforcement approach. Plus, these are the few other things that I was going to explain to you, as I mentioned a couple of minutes ago. So in this package, in addition to the first two components, there is input in relation to myths related to alcohol use and tactics of the alcohol industry and stereotypes related to alcohol use. So there are lots of myths related to alcohol use. I mean, we sometimes think that if you take alcohol once, you will never get out of it. If you take cocaine once, you will always become an addict. And Dr. Abhisinger nicely showed us it's not the case. With figures as well as the example of very low prevalence of alcohol use in Sri Lanka among women. So I mean, we generally believe certain things and we take them for granted, but when we look at them carefully, you find that there are so many myths related to alcohol as well as other substances. So that is one thing we encourage the patient to look at. And then the tactics of the alcohol industry, how they affect, and in creating the substance facilitating culture, which Dr. Abhisinger again mentioned. There's a huge amount of work being done by alcohol industry as well as the tobacco and the cannabis. So if the patient becomes aware of these tactics, he or she becomes more immune to these tactics. And there's the stereotypes related to alcohol use, the drunkard, the bebad, the kudukarya, the ones who are a kudukarya, always a kudukarya, and if you are a three-wheel karya, you are invariably a smoker or a kudukarya, that's, these are the labels that are attached, the stigma. And even the family doesn't believe, when you say that you have stopped your heroin use, the family doesn't believe. So these stereotypes. So all these are explored by the therapist, patient, family as a team in order to recognize, overcome barriers to changing the behavior of the patient and the others. Right. So, so the main three components are the myths related to alcohol, the additional components, tactics of the alcohol industry, and stereotypes related to alcohol use. So I leave you with these questions, which are related to these three novel components of this multimodal psychosocial input. So I'm not going to answer these questions. It's for you to think about, quite in parallel with how Dr. Abhisinger finished his speech. So for question one, how much psychoactive these substances are? Do they actually produce these psychoactive effects? Any randomized controlled studies on psychoactive effects of substances? How long does it take to produce significant blood alcohol concentration in a typical drinking session? Why some people get drunk way before this significant alcohol concentration is achieved? Sometimes even before starting drinking. Some people get drunk even before starting drinking. How come drunkard behavior instantly disappears when the police arrive? Why dopamine surge in reward center is not demonstrated in alcohol or drug naive persons? It's usually, it's found in the veteran users. And how to explain dopamine surge in internet and other addictions, which Dr. Abhisinger mentioned a few minutes back. And what is happening behind inclusion of these kinds of scenes in very popular teledramas and movies? If you are interested, you can go to this website, cct.lk, tobaccounmask.lk. So the first season, for an example, if you take Devani Inima, first season, there were no appearances of alcohol and tobacco. In the second season, now it is very popular, there are numberable examples of portrayal of alcohol and tobacco. why, how these things happen. So that is the multimodal psychosocial therapy. So you don't have to really, adopt that as a package, but think of these novel areas which are relevant in practicing or in helping, in trying to help patients with addiction. Thank you very much.
Thank you, Magesh, for that interesting lecture. So now the floor is open for the questions.
Thank you, Mahesh, for that interesting presentation. This is Gihan here. Can I just ask you a question now? As you know, the heroin dependence in Sri Lanka is on the rise, and we have to deal with a lot of, and we know that brief intervention methods are very effective in all kinds of substance use disorders. So can you please outline the main components of the brief intervention package that we can use in the context of, in our context, in the Sri Lankan people who get used to heroin? What should we do in Sri Lanka? We know the principles of brief intervention that they use in other countries, but have you done that in Sri Lanka, and specifically in the heroin dependent people, and how effective that can be? Thanks.
Thank you, Gihan. So I can't give a lecture now based on that question. So just a couple of principles. One, consider that this could be the last time you are seeing this patient. The patient might never turn up. So use that opportunity. Two, address the concerns the patient has. Usually the patient has come asking for medications for his withdrawal symptoms. So do that, attend to that immediately. Three, try to get the patient to think differently about his substance use. Do not let this interaction of the next few minutes be a script that has been written by somebody else and enacted again and again and again. That's what happens. Patients come, have the same conversation, and say this and that, and go back to where they were. Especially in heroin, the person is completely plucked out of his or her, usually his normal psychosocial environment, family, friends, and planted in some other place and completely subject to the dynamics of this heroin culture. So getting the person back into this family or whatever social psychosocial environment is the key. For that, I can't give that in a simple 1-minute answer. For that, you need to activate many mechanisms involving the family and the patient to get the patient back re-implanted into the place where he was. Thanks.
Thanks, Mahesh.
Thank you. People are also welcome to send in questions through the chat. Mahesh, they may be collecting questions to ask you at the very end.
Thank you, Tini.
Yes, Kamal, did you want to ask?
Yes, thank you for giving me the opportunity. Can I ask a question from Dr. Rajeshwari, and also Dr. Abhay may also answer? Now, we just spoke about brief interventions in opioid use. Well, I have worked in an addiction center in Australia. Our experience there, also the brief interventions don't work in opioid dependence, and as far as I know, there's little evidence in brief interventions in opioid use. The efficacy of brief interventions. I would like to ask from Dr. Rajeshwari about your personal experience in brief interventions in Sri Lanka, with the brief intervention alone as a primary care level would assist these patients from abstaining from opioid dependence. Thank you.
Thank you, Kamal. That's, your question again highlights that the focus on use, can it help patients to abstain from heroin use? I mean, that's only one of the questions that you should ask when you see a patient. How can I help this person to abstain from heroin or whatever? But there are so many other important questions that you need to answer. So that's one thing. But about the brief interventions, you are thrown in at the deep end and the patient comes and the patient might never turn up again. You have nothing but the brief intervention for many of them. So you have to depend on, you have to do something for these patients rather than just turning them away. So that's one thing. However, the rigorous methodology being used to test the brief interventions in Sri Lanka, I don't think it has been done. I have tested the multimodal psychosocial package for alcohol. I can give you the results of that, but brief intervention, I don't think there has been a proper study in Sri Lanka to test that. I think we need to, but don't forget that many of the patients who get better, improve, not only abstain from substance, there are so many other things for the patient to improve, might never come back to say and thank you, to see you and say thank you. So we don't see that proportion. So we think our brief session we had that patient never worked. They don't come back to tell us that it worked. So we need proper studies to follow them up and see what happens.
Thank you very much.
Are there any more questions?
Mahesh, what do you think is the biggest challenge? Mahesh, what do you think is the biggest challenge? Is it tobacco or is it alcohol?
The biggest problem?
Biggest challenge to control.
Biggest challenge to treat, of course, yes. I think it's alcohol because comparing these two, tobacco and alcohol. Now, as I told you before, the heroin completely unplugs the person and puts him in a different world, which is a very narrow world. The world of the heroin user is very narrow, right? Hopelessly hopeless. Alcohol does it to some degree. Tobacco does it to a lesser degree. So quitting tobacco and getting back to where you wanted to get back to is somewhat easier than stopping alcohol, because alcohol is connected to your friend circle, the clubs you are attached to. We know the clubs, there are people who use a lot of alcohol are notorious to join. So you have to change a lot of things. And the way you have been, your wife may be very arrogant, and the way you have been dealing with that is by using alcohol. Now you have to find a new way to deal with your arrogant wife. So lots of things to be done in helping a person to change his world when he's using alcohol. So I think alcohol is the bigger challenge compared to tobacco. And the research shows that up to 80% of tobacco users has quit tobacco use. They have not looked at the other outcomes, only the use, without any professional help. So up to 80% of tobacco users have quit without any professional help. So it's probably easier.
Thank you. Any other questions from the audience? So in the absence of questions, shall we conclude this? Thank you, Mahesh, for this interesting lecture and the overview, including the biopsychosocial aspects, the holistic management. Hope to treat.
Thank you very much, Mahesh. That was very interesting and informative. And now it is actually with great pleasure that I invite our next and final speaker for this symposium, Dr. Kapila Ranasinghe. Dr. Ranasinghe is a very well-known prominent psychiatrist based at the National Institute of Mental Health. And in his wide-ranging career, he has had many positions, including he is the former chairperson of the Board of Study of Psychiatry at the PGIM, and he is also the president-elect of the Sri Lanka College of Psychiatrists. And he's going to talk to us today about the pharmacological management of addiction. And Dr. Ranasinghe, can I warmly invite you to update us on this topic? Over to you.
Yeah. Thank you very much, Tilni, for the kind words. Let me First of all, I'm thankful to the Sri Lanka College of Psychiatrists and the Clinical Society of Trincomalee for organizing this webinar, which is timely and much needed. I know we all are managing substance use, but sometimes the way we manage is questioned by politicians and other colleagues. So, and the evidence for management is also changing rapidly. For example, while preparing this lecture, I went through the mostly guidelines. Even they have changed their guidelines in managing pharmaceuticals. So I thought I will mainly focus on latest development and practical management of addiction with pharmacological means. First of all, two speakers actually made my presentation easy. So while preparing, I had to change some slides. I would like to, I like this guy, Frank Tallis. He's more popular as a writer and a psychologist. He was in the Institute of Psychiatry. I've seen him. He's the one who first told that people initially take substance to feel happy, but then they continue to take it not to feel unhappy. This is his statement. He has written widely on how the psychopathology, psychology changes, the brain changes, seen with substance use. And I think he had touched the areas of behavioral addictions, sexual addictions as well. Right? So basically he was saying, initially people start taking substance in an impulsive manner, and it gradually leads to the neuroplastic changes, resulting in compulsive drinking or taking substances. I won't go to the details of the neural circuits, the ventral circuits, and how it migrates the dorsal circuit, because Dr. Abesingha very nicely showed some of the diagrams in detail. But the important thing is a lot of areas in the brain are important in handling substance use disorders, whether how you intervene, whether psychosocially or pharmacologically, we have to address these issues. And evidence for right now is most of the substances are best managed with psychological plus pharmacological management. I'll come to one by one with them. Now, in pharmacological interventions, because of the models shown by especially Dr. Ranila Abesingha, who is my dear teacher, it should aim at, should aim at reducing craving and whatever the rewarding that the substance is giving, right, and relieving the bad effects of the withdrawal and the treating toxic effects of the substance. Because this component is very important, especially in substances like alcohol, heroin, and some stimulants, because the permanent changes that are associated with the substance use may not reverse without treatment of the toxic of the substance. So, I mean, Dr. Maheshwari explained, craving can be both reduced psychological means as well as the pharmacological methods. So we'll be coming by substance use, because I'm aware that a lot of trainings and other academics are involved here. I thought of going for a brief discussion on with each substances, right? Now, when you consider, we classify these substances. Most of the substances are now popular substances. One of the main problems in Sri Lanka, at Mahesh correctly, is the most challenging probably is alcohol. And on top of that, we see a lot of prescribed substance dependent people. GHB and kava is less in Sri Lanka, but these are main issues. So I'll touch on alcohol. Now, very interesting, the phytopharmacological aspect. Now we are aware the doctor, as Dr. Abesing highlighted, now in anyone, there's a GABA and glutamic homeostasis, but when a person get intoxicated, the GABAergic axis is enhanced, and with the chronic use, glutamate start to get upregulated. And we are all aware that glutamate hyperactivity in upregulated brain results in a withdrawal state, which is very unpleasant and painful and can go to leading to very detrimental consequences. So it's very important to know the timing and intensity of alcohol withdrawal symptoms clinically in order to manage. Now, this is the most important curve, I guess, anyone who wants to manage, one should not lightly take severe alcohol use disorders, or as the ICD-10 system says, alcohol dependence syndrome, because some of the withdrawal syndromes can damage the brain. So unassisted alcohol withdrawal management is inhuman as well as unethical and unscientific. And because of the consequences, as you can see, from the initial phase itself, because of the glutamate toxicity, one can get seizures, and then the delirium tremors, and the other withdrawal syndrome. Right? So I will not go to the, but this is academically very important when you are managing the pharmacological management of the withdrawal. Now, benzodiazepines are the gold standard to reduce withdrawal. It reduces both incidence of seizures and delirium tremors. All the detrimental consequences are reduced by benzodiazepine. And trainees are aware that there are 3 types of dosing regimes: more fixed dosing, symptom triggered regime, loading dose regime. Each regime has its own advantages and disadvantages, but I'm not going to detail that. But very important to know this part, whether now we usually tend to prefer long-acting, mostly chlordiazepoxide and diazepam, because it gives a smooth course and it has a lower risk of rebound symptoms. But we may not be able to do it in certain settings. Especially now, I am handling a lot of geriatric patients and some patients who have liver disease. They need short-acting one, and even lung disease. And recently, I've seen in the private sector few cases where COVID patients are having alcohol withdrawals. So they were all put on shock-acting. For academic purpose, I also covered the carbamazepine, valproate, and gabapentin, which is mentioned, but they are less used actually. Especially, you have to be very careful with carbamazepine, and it's almost outdated. Nobody tries it. Even when valproate can cause similar side effects like withdrawal, the gabapentin. So these are usually considered when there's a higher risk of seizures during the withdrawal, or there's a past history of withdrawal seizures, and there's real withdrawals. One has to be very careful, withdrawal seizures, be careful in selecting them. And few other substances are also being used when the withdrawal symptoms are nasty, especially clonidine, propranolol is being used by medical people when there's the impending delirium tremors. But baclofen, many research articles emerged during the last few years, but when you look at them, they are less useful and there's weak evidence. Barbiturate, again, kind of becoming more and more obsolete. And sodium oxybate is only approved in few countries. I thought of touching Wernicke encephalopathy because severe alcohol withdrawals can result in significant neuropsychiatric sequelae. One of the main common identifies Wernicke's encephalopathy and Korsakoff syndrome. Now, nowadays we tend to identify these syndromes separately, like fronto-subcortical syndrome, secondary alcohol use, right? Like frontotemporal disease, temporal amnesia, secondary alcohol. So there are different topics, but technically when you are managing a person with suspected neuropsychiatric sequelae during alcohol withdrawal, these are the regimes that you should consider. Because if you don't attend it to with proper supplementation, the neural damage will continue. Now, it's important to start thiamine high doses, especially 500 milligram 3 times per day, and then magnesium with severe TD, NK, right, and other B complexes. And Hosakov, they are actually going to permanent changes. The brain, nor the pharmacological management is of very low results, but thiamine supportive care and long, more than 6 months of treatment is recommended. Then coming to relapse prevention in alcohol use, it's important now to prevent the impulse stage as well as reduce pressure from the substance, right? So we are, by relapse prevention, we are targeting to reduce craving, aiming at relapse prevention. Naltrexone is quite effective, so I won't go into details on naltrexone, but in other countries they are using naltrexone depot. And acamprosate can be used in patients with hepatitis or liver disease, significantly reduce risk of return to any drinking. It increases the humidity duration of the abstinence, but it does not reduce heavy drinking. The problem with acamprosate in Sri Lanka is, I think, that it's expensive and you have to take in divided doses, so supervised treatment is difficult. Now, one of the cheap molecules that had been there from the days of our training is disulfiram. I was happy when I saw that there are new evidence, fairly not that much new, evidence that supervised disulfiram is effective and probably more effective than naltrexone, acamprosate, and topiramate. And average treatment effect sizes for naltrexone is low. You can see the 0.28, acamprosate 0.26, supervised disulfiram is 0.53. And disulfiram is efficacious for maintaining abstinence or preventing relapses with acamprosate and naltrexone. So for some odd reason, it has lost its pharmacological magic due to no one is marketing it and hardly any research evidence coming in major journals. So, but it's quite useful. I personally use it, and it works very well when there's supervised treatment. Second line and cravings, I thought of for academic sharing, but topiramate is less well studied. It has adverse effects, not that great in reducing relapse prevention. Again, gabapentin, similar to the evidence, is not that great. And coming to stimulants, right? The time constraint, I will not detail about stimulants. They cause a lot of these kind of problems when they're abused. Right? Main one is nicotine. With when you combine with psychosocial interventions, first line is nicotine replacement therapy, varenicline and bupropion. And for harm reduction, they may not quit it, and to engage, keep them engaged in treatment, again, nicotine replacement and e-cigarettes are recommended in certain countries in policies, but not in all countries. We'll come into that. Now, odds ratio for abstinence from any form of nicotine reversible versus placebo is 1.83. And odds ratio for abstinence for combination of nicotine treatment with single is 1.43. That shows that combined treatments are better. Right? And Cochrane study that which included 136 trials of 64,000, more than 64,000 people put on NRT. The chance of quitting increased by 50 to 60%. The quitting rate is very high if you keep them with the other therapies. Varenicline is a alpha-4 beta-2 receptor partial agonist, which is widely used in certain substance use clinics, mainly with the walking clinic. And it does not cause upregulation and sensitization in acetylcholine receptors. It has a relatively long half-life. And it's actually more efficacious than bupropion, and it gives overall excellent results in quitting smoking. Bupropion inhibit reuptake of dopamine, noradrenaline, and serotonin, and it's a non-competitive nicotine receptor antagonist, right? And it achieves long-term abstinence. 19% of smokers who use it to quit. And it attenuates the weight gain that often occurs after quitting. This is one of the bupropion with comorbid depression, comorbid low sexual desire is actually good results. Bupropion is becoming slightly popular in certain countries because of these results. I myself have just used bupropion. It works very well. Then second line, these are mentioned in textbooks for completion for the trainees. I mentioned this. Nortriptyline and cysteine, both are not available in Sri Lanka. Efficacy is not that great, right? So when you are sharing, because of the time constraint, I will not go into detail, but I'll mention it. Now, e-cigarettes, which was sold through the internet in Sri Lanka, had mixed evidence for smoking cessation, but it had reduced health harms related to combined tobacco products, combustible tobacco, right? And long-term health effects are not yet known because they have been in use for less than 10 years. There are different type products, so but it's not recognized as a nicotine replacement therapy, but it's more for harm reduction when you don't have anything else to offer the patient, rather than just to keep them engaged. Yes, but nowadays we don't prescribe it. Nobody prescribes, but if they are willing to take it, there's no point arguing with them, because and gradually engage them get them to quit completely. Coming to stimulants, the amphetamines, this is again a problem in Sri Lanka. It's going up. The so-called ICE use, methamphetamine use, is increased. Sorry. It causes amphetamine withdrawal. I have seen in teenagers, young adults. Right, methamphetamine withdrawal causes dysphoric mood and very unpleasant. So they need some supportive treatment. There are no evidence based for direct pharmacotherapies. So we do symptomatic medication. Some of them are very aggressive, angry, and can have comorbid psychotic symptoms when they are combining. Now, amphetamine alone does not occur in certain groups. When multiple substance users, methamphetamine plus cannabis plus a lot of alcohol, they need symptomatic treatment. The potential other candidates have been mentioned in academic forums, right? Dexamphetamine and fexofenone. Now, how to treat? Because I am sure the most of the psychiatrists must have seen the ICE users. Right? It's not going to be easy. As Dr. Ranila Basing correctly said, a lot of them have actually ADHD probably. We have missed them, and they're very hyper, having conduct disorders, not easy to engage even. So dexamphetamine, they have tried in other countries, not promising results. And methylpentane, which is Ritalin. Then lisdexamphetamine is one ongoing study where a few countries are still using. And somebody, I think, naltrexone, again, missed result. So technically, I saw the chat line. I think Mahesh said that the naltrexone works blocking the reward loop for everything. Need to be explored further. I think there's no hard evidence to support that. And tepromate reduced use and addiction severity. And interestingly, mirtazapine had been used. Maybe the anxieties, the dysphoric mood is improved by mirtazapine. So I also have used when they're aggressive, having dysphoric, anger, continuing use, risperidone low dose plus mirtazapine may work. Then coming to opioid, there are a large number of opioids, but out of them, I think in Sri Lanka, mainly heroin is the main dependent. Very few prescribed opium dependent people are there. Now, in coming to opioid management, it's important to understand that there's 3 lines of management. First is the crisis intervention, then abstinence-oriented treatment, and the agonist maintenance treatment. This part we don't discuss that much in Sri Lanka, but I realized while working with the other colleagues in physicians, HIV medicine, these are major important issues, crisis intervention. They can have fatal overdoses and get rushed into emergencies. So we need to treat them with short-acting opioid antagonist naloxone. Whether how you administer that doesn't work, naloxone is still available in Sri Lanka widely. I think it was available time and it's gone now again. But hopefully it will come because prescribed opioid overdose also emergency departments in private sector. I was told it not easy to handle it. Then opioid substitution treatment. Again, it gets divided into 2 axes. One is the detoxification and relapse prevention, and maintenance therapy as a harm reduction. Detoxification, right? Oral substitution therapy, starting and tapering off. Methadone and buprenorphine both have been discussed in all the textbooks and it's recommended, but in Sri Lanka, both molecules are not available at the moment. But they give, out of that, it will know that buprenorphine tapering is more effective than clonidine and others, lofexidine. The clonidine I have tried, it very severe, it works, but in detoxification in Sri Lanka, we mainly try symptomatic treatment and when there's significant disturbance, we even give low dose codeine and paracetamol combination. Especially, I am sure that you are aware that during the first wave of COVID pandemic, we had a large numbers of heroin addicts coming to National Institute of Mental Health. They were having withdrawal symptoms, and even private sector they were coming. So we were giving symptomatic treatment, mainly paracetamol. Then it doesn't work, we actually manage them with paracetamol codeine combination. And worst case scenarios, when they were trying to escape climbing walls in our wards, we were even compelled to give tramadol and tail off. Even we manage a lot of COVID centers through our calls. Even in those units, that has to be given. But that's not mentioned in any of the guidelines. So that's why I didn't write it here. But detoxification is very important because they cause a lot of havoc and behavioral symptoms in acute care settings otherwise. Now coming to relapse prevention, naltrexone is the model anti-craving medication according to a lot of evidence, I think, right? But it does not have any benefit in retention in people. Side effects or relapse result even when compared with placebo. Even in the private sector, this is my experience, if they are supervised treatment and they are highly motivated, naltrexone works. Otherwise, it gives very low results. See, you can see only 4% of patients were still in the treatment after 6 months, even in Australia. Now, this is Australian study. Australians feels buprenorphine and methadone were preferred over naltrexone, and even a lot of other clinics, because the retention in their clinics and retention in the services is better with other, of course, other substitution therapies. And so the naltrexone is recommended to be prescribed, right, only for highly motivated, stable, and productive people. I think that slightly applies here. When there's good family support, they are motivated, they really want to come. I think and the environment is risky. Yes, naltrexone works. Some of the people that we treat, they are working in subcultures or living in subcultures that are where heroin use is rampant, and they are easily invited by their colleagues and friends to try again. Naltrexone works. So that's why this treatment has to be tailor-made and very specifically used based on the context and the needs of the patient specifically. Now, maintenance therapy for the completion. One of the main areas is, now we all know that the maintenance therapy is mainly given for risk reduction. It is well known to reduce heroin use, reduce HIV risk behavior, and criminal behavior. Right. These are the three combinations. Now, methadone is the main product. Right. It reduces heroin use and reduces criminal behavior. But very high doses are needed to eliminate the heroin use. So, substitution with low doses and yielded no results. And so, they have to be engaged, and will tailor-made therapeutic packages have to be delivered. Right. And buprenorphine has lower mortality rate compared to methadone and high rate of conversion. It's recognized with buprenorphine. Right. Then now the latest is buprenorphine and naloxone. Buprenorphine and naloxone combo, a low abuse potential but equal efficacy of reducing the use and the craving. One of the main arguments against introduction of methadone and buprenorphine in a lot of developing countries and poorly service developed settings is that the potential for abuse. I think in the Sri Lanka also, the discussion is whenever methadone is discussed, this discussion emerges about 30, 40, yeah, 30, 20, about 30 years back, it was introduced in Sri Lanka and it was abused, and our systems were not developed enough to supervise the treatment. So in that context, we may, when the services develop, we may have to think of bringing up, or if we want to bring up, buprenorphine and naloxone-like product with the low potential for abuse. And this is for academic purposes. Pros and cons of methadone, all the trainees and the academics need to be aware. Though it has high retention rates in services and saves 2 lives for everyone lost per year, reduces heroin use and morbidity, reduces criminal behavior, can be used in pregnancy as well, and stabilizing the life in early users, right? But these are the concerns. The methadone is well known that it is high risk if taken in overdose, and potential for serious side effects, especially cardiovascular, and potential for abuse and high service demand. So it's very expensive to run the services because one need to register them and monitor them. Some very carefully planned services need to be done to prevent the abuse and pilferage of the methadone. Coming to cannabinoids, there's no optimal medication, right? This is one of the main issues. A lot of mothers their spouses come asking for help for severe cannabis use. Right? There's no pharmacological management. When they come along, I say that bring your partner or the child, then we'll start engaging and treating. Because the evidence is very small and with mixed results. They have tried everything. Here also, what we do is based on the comorbidity, we try and symptomatic treatment, then usual psychosocial management of substance use. Not easy. Harm minimization, we try. It works depending on the patient and the support system available for the patient. Now, these are the treatments that are recognized, right? But not available in our part of the world. Donabinol is a cannabinoid again. This is equivalent to a oral replacement therapy, and N-acetylcysteine. So far, the most promising, but it reduction in self-report of cannabis use and cannabis craving. It's supposed well recognized as a well-tolerated substitution therapy for cannabis users. Then coming to cocaine. And now cocaine use is probably going up in Sri Lanka in higher social classes and among certain social groups. I personally have seen few. It's again the culture. Promoting culture is the one there, and it blocks dopamine reuptake and gives this high and euphoric feeling. It improves the group to make this academic activity, right? But cocaine also causes withdrawal. So this is one maintained, as I introduction the Frank Tallis, right? The cocaine users initially take it to feel good about them, happy. Then they actually continue to use it not to feel unhappy. There's hardly any happiness in them after a while, right? And so as a result, they have withdrawal, this dysphoric feelings among them. And no FDA-approved medication or symptomatic treatment is suggestible. So cocaine treatment, again, depending on the comorbidity, the nature of the presentation, we may have to handle them. I'm not sure whether they live outside Colombo or other cities, but majority are probably concentrated around Colombo, perhaps. Cocaine, again, no pharmacological again, right? Agonist treatment, long-acting amyloid. Now, this is the other thing. When they are addicted to stimulant, treatment risk minimization can be by substitution with a long-acting another stimulant. Modafinil is well known to give alert feeling and the withdrawal like feeling relief. Modafinil is used for narcolepsy and as a third line for ADHD and certain disorders where sedation and poor concentration is noted. I think I also have given modafinil 1 or 2 former multiple drug users who find it very difficult to concentrate during the daytime and they feel lethargic and drowsy. And it had worked. And topiramate, of course, does not work, though it's mentioned. Then psychedelics for completion, not being used in Sri Lanka. As you are aware, psychedelics cause psychotic symptoms, other distortions in perception and reality distortion. Dependence is typically psychology. No physical dependence is noted in psychedelic. And management is supportive care. Empathogens, again, MDMA and the stuff are very rare or not being used. Right? They are recognized as giving these kind of feelings. And toxicity is the main problem. I think hypothermia, dehydration, seizures, hypertensive crisis. So again, supportive symptomatic treatment need to be given to them. So coming to them, I think I managed to cover the area because it's when I was given this topic, I told this not easy to cover topic by topic of pharmacological management of substance use. With each topic itself needed a separate time. But I would like to end this by saying, reminding what Aristotle told. We became temperate by abstaining from indulgence, and we are better able to abstain from indulgence after we have become temperate. So almost whatever the treatment we are giving need to be considered with psychosocial interventions and should be tailor-made to the needs of the patient and promote temperance, perhaps. Thank you.
Thank you very much, Dr. Ranasinghe. That was a very comprehensive and detailed presentation, and I think very useful for all the listeners and especially the trainees. So this, I mean, I'm sure everybody has a lot of questions. Is there any questions from the audience? To start off, there were a few questions in the chat. So,
yeah, okay, press it. Oh.
Yeah. Can you see them, Kapil, or I can? So there was one question, a straightforward question as to whether bupropion is available in Sri Lanka.
Yeah, it is available.
Okay, all right.
And bupropion is available for during the last 2 years in Sri Lanka. Not that expensive, but I think it's quite acceptable by the smokers. Even female smokers who were worried about mainly the weight gain after quitting, they were quite useful. And when there's comorbid depression, it's quite useful. But one need to start with 150 milligram in the morning and needed increase to 300. One of the main thing that it's quite activating and alert. Bupropion is an interesting molecule because of the structure and the pharmacokinetic nature. Initial tolerance is a bit difficult. The loss of appetite is felt. Then, so you have to instruct them to take full mouth, full stomach. But then later on, they tolerate. Actually, it's well tolerated.
And there was also a question, Kapila, about how well does OST, must be opioid substitution therapy, how well does it retain people in treatment? What are the percentages compared to psychosocial treatment?
Yeah. Now this is, I didn't highlight, actually I removed that slide because of, now psychosocial treatment, I think opioid treatment, psychosocial treatment, that Kamal said, very low retention levels. I actually removed the slide because I thought I won't be able to cover it. Psychosocial intervention, retention is very low. Especially motivational interview, very low. We can actually discuss it maybe in a different forum. One of the main pitfalls that even in the clinics that the highly dependent individuals come with heroin, and when we offer only motivational in the psychosocial intervention on the first instance, right, they are disappointed and they disappear. So retention and engagement is very high with oral substitution therapy. That is the one argument. So, but it, I showed all the dangers of and how expensive it is going to use it in Sri Lanka. I think I'll go into that.
Okay.
Yeah.
Yeah, that's that. You did touch on it.
Yeah.
There's also a question about, sir, what is your opinion and experience about giving tramadol and precab to heroin users in outpatient settings?
Now, till now, I don't give tramadol unless actually in the NIMH we were compelled to give very severe drug users. I think that happened during the COVID pandemic crisis. Now I was seeing the Bandaranaikapura service area is mine. All these drug users who spread COVID-19 at the first time, right? They were they were kind of craving and causing havoc in the wards. I mean, we ended up restraining 10s, 15s, 20s in wards, so that was difficult. So they only when a few of them again needed. So majority we were managing with Panadine actually. That's a combination of paracetamol plus codeine and then symptomatic treatment. So long-term treatment, I don't believe it doesn't work, right? Initially, what we did was substitution and tapering off in all of them. Even Panadine we didn't give long-term. I think it's useless. Giving them so psychosocial intervention. So and those days we were kind of monitoring our services, even in NIMH, substance use clinic. The retention is the main problem. They drop out.
So it is mostly Panadine in the initial stages.
Mainly the acute detoxification, mainly Panadine plus the other benzodiazepines. Sometimes we were giving even promethazine.
Okay.
Symptomatic treatment based on the presentation and the severity of the heroin withdrawal.
Okay. So there is
and some of them were actually kind of, I mean, you know, this area, Bandar, they were kind of having more dissocial traits. So more risperidone than tramadol were given to them.
Right.
To contain them.
Okay, so there's a couple of questions about medications. So there's a question whether there are alternatives available for naloxone if that's not available, and also alternatives for baclofen. Or your
baclofen is available in Sri
Lanka. If you use, can you use baclofen?
Baclofen. I have used it very few people, but now baclofen is is one of the researcher. The evidence shows that even with impaired liver function, baclofen can be used. But anti-craving properties of baclofen, my personal experience is poor.
Not much. Okay. And any alternatives to naloxone? There was a question from one of the
naloxone, I am not aware now. Not in Sri Lanka. But it's becoming a problem. It's intoxication and severe overdosing of substances. Okay, kind of bit of a problem in some of the emergency units in private sector as well as hospitals.
Okay. Dr. Gayani Sirivardhana has quite a long question. Gayani, do you want to unmute yourself?
Yes, she can ask it. Yeah.
Ask Dr. Kapilarana Singh? Just because it's quite long. Did you want to explain the question?
Yes, sir. At the base hospital Dambadeniya, we have a separate substance clinic, and we see quite a lot of number of young men coming with heroin dependence. More than 90% of the patients are having heroin dependence, and one of the major challenges that I face there is most of them have severe withdrawal symptoms, and one of the major reasons for the continuing use is actually the withdrawal. I came across some local guidelines recently. Actually, I had just an image forwarded to me by another colleague. My impression was that it's a local guideline produced by a project which was conducted by NATA. And apart from the usual regime, which consists of NSAIDs, paracetamol, antihistamines, and so, they have recommended olanzapine 10-octane and chlorpromazine 100 milligrams TDS for the initial management of the withdrawal. So I actually was a bit dubious about the research evidence. So I thought that maybe it's better to discuss that during in this forum. Are you aware of that, and sir, are there any research evidence for the usage of such antipsychotics in the management of the heroin withdrawal in the initial management?
I'm not sure how it came, but I was also shown the same evidence. Now, one of the, you are correct, the fear of withdrawal. That's why I mean, conceptualize this problem. They continue the substance use not to feel unhappy. the withdrawal is very unhappy, dysphoric state, even in the mildest form. And these guys, the lower social class, they had to continue to work. They had to go home, attend to their other day stuff. They find it very difficult with the withdrawals. That must be one reason they keep on relapsing, going back to different types of withdrawal. So symptomatic support, other means of supporting them is very important. And it's well known now, this sleep disturbances following heroin withdrawal persist for long periods, depending on the nature of the problem, abuse and their problem. So even I have seen some of them need, I have ended up giving quetiapine, right? Because the low dose quetiapine is a hypnotic. It doesn't have any other properties for heroin, but maybe it's a misinterpretation of that, not to have produced that. Whereas giving olanzapine can be detrimental as far as sedation, metabolic side effects. I don't know how that came to that document. But addressing the symptomatic support, giving them will help them to engage, definitely. Maybe promethazine when there's nothing else, but promethazine again is a very poor hypnotic compared. Maybe quetiapine is better, I think. My anxiety, even low dose quetiapine, maybe, and you are correct, a lot of them have a lot of anxiety as well during the withdrawal. So that's why this stimulant withdrawal, the mirtazapine, it's quite anxiolytic. Symptomatic treatment we are considering, maybe knowing the pharmacology, you have to use it.
Right, sir.
Okay. Can I say something?
Yeah.
Yes, sir. Of course.
I think I'm really surprised that NATA made these recommendations.
I have seen it, it's there. I don't know how it came.
I don't know how they came came out with it, because there is absolutely no evidence anywhere in the world that olanzapine and chlorpromazine work, because that's a very amateurish job they have done in that case. They even in the if you look at the WHO recommendations, that they other than methadone and buprenorphine, it is clonidine that is being
clonidine, that's why I mentioned
recommended. So that in the Dambadeniya clinic, you can certainly use clonidine in higher doses, and that I beg to disagree with Kapila on this. That is, I think there is a place for tramadol in the treatment.
Yes, I have used tramadol side, but it very precautionally.
Their hyperalgesia is so much, and that Panadine or codeine will not help them, because this is one
depending on the severity, maybe Panadine plus
tramadol.
So
tramadol definitely has a place, and the tramadol is available in hospitals. And
it is available in hospitals. It's licensed in Sri Lanka.
Physicians use it, neurosurgeons use it, the neurologists use it. I don't see a reason why psychiatrists are so careful, that they don't want to use tramadol. My advice is use tramadol, because we are trying to get these people out of a very difficult drug addiction, and that if you have to use powerful drugs, you be there, use it, because heroin dependence is not an easy thing to get out of. I mean, if you have to use, if the patient has difficulty sleeping, use benzodiazepines, because benzodiazepines will not kill, right? If they have severe neurogenic pain, use it. Use tramadol. And also, there is one trial about pregabalin use, and it produced a sort of beneficial effect, but it has not been used extensively in other countries. But for some reason, our patients, I think it's in the part in the culture that they keep asking for pregabalin. And again, I don't see a reason why we shouldn't use it, because it's a good anti-anxiety agent, and that is good for neurogenic pain. And so, because my approach is, it's a very difficult condition, and that it affects these people so much, and their families, and the society. And that if we can use any medication, short of giving them heroin, we should use it and try and get them out. The main reason why they don't come back to us is because we are not using powerful medication, right? And I'm already developing a series of patients who are being treated by me. I will one day present it. And right, so for the moment, I'm keeping the data with me.
Sir, hello.
Yeah.
Yep.
Hi, everyone. Thank you, Kapila, for that wonderful presentation. And
Thanks.
Sir Paba here. So don't you think tramadol and pregab and all those are lesser devils? Because they are also addictive. We handle tramadol addicts. We handle pregab addicts. What is your view on that? I mean, kind of get what you say, but they aren't the lesser devils.
Yeah. So I mean, so is methadone, right? That if we can,
I know.
If we can use any legal drugs that that we can try and help them to get out of, that I think we should use it, because most, I mean, my experience that in most situations, most of these patients, they gradually come out of the tramadol, because their hyperalgesia has to be addressed. It can last up to 6 months, even longer. And that is, in the absence of methadone and buprenorphine, we have to use these things. I mean, I know we deal with benzodiazepine dependence, but that's another matter. Because that's much of a lesser scale. And so we need to address the severity of the problem, where people die, members get killed.
Can I say the floor is open for discussion? So if there are any other views, opinions, please feel free to.
Yeah, I think I agree completely with Dr. Anila Singh. One of the main problem that we had dealing with this Bandarnagapura population, right? They keep on relapsing because the craving is so bad, as well as the dysphoria feeling given the withdrawal. So once their families are asking for support, and you need to understand the intelligence levels and the social class. So they have less time for more other intervention. So they were kind of requesting some kind of a substitution therapy, but we had nothing to offer. But with symptomatic treatment was offered mainly from the clinics.
Are there any other comments?
May I add something for this? Now, thank you very much, Sir, for actually enlightening on us on this very important issue. Now, my experience in Australia is now they basically used medications to attract these patients to the services, and they have a short-term goal and a long-term goal. They were not very keen on maintenance therapy actually, but they used methadone and buprenorphine to control withdrawal symptoms, and then they used a lot of psychosocial interventions to help them abstain from medications. So I think we also should have some kind of medications to help these patients, because at the beginning, psychosocial interventions alone may not help these patients. And but I'm not sure about the feasibility of maintenance therapy in Sri Lanka because of the poor system and other problems that may arise. And tramadol, of course, is an option, but I also would like to raise this issue. If tramadol is used by all the medical officers, that can cause problems. So in most international guidelines, opioid withdrawal is done under specialists who are specialized in addiction medicine. So as we don't have addiction psychiatrists, I think if we can get the permission from the authorities to use tramadol only by psychiatrists to treat opioid withdrawal symptoms, that would actually minimize problems that may arise in the future. Otherwise, it may cause problems, because then there'll be an abuse of tramadol and other medications that we may use. Yeah, thank you very much.
Yeah, Kamal, important point. Now, I am completely kind of with you regarding tramadol, during the pandemic first wave, when we were preparing the college guideline, tramadol was mentioned. Actually, we were, whether we like it or not, all the COVID centers were using it. I mean, I remember Dr. Monaragala, the Army's chief medical officer, chief psychiatrist, he was saying that uncontrollable, and we had calls from all over the country. They were trying to retain heroin addicts. They were roaming around, and tramadol was widely used. So temporary use was quite good. It helped, and we were using it. I am complete with, but I was a bit reluctant when put it into the guideline, right? Yes, as you said, so there's no restriction that it can be used in a designated services like psychiatric services or a substance use clinic. Everyone will start producing. So we'll be making more and more prescribed medication dependent individuals. So they will start sharing. That's the danger of prescribing tramadol in an open manner. But of course, in a supervised designated clinics, I think it has a role. So in that way, again, methadone and buprenorphine will be lesser heavy.
One of the things about heroin and tramadol is that tramadol is only 1/10 effective as
heroin, sir, yes.
As heroin. So
yeah, that's true, sir.
No heroin abuser dependent patient is going to be
no heroin dependent. Our concern is, sir, that the medical officers who are not in psychiatric service, the private sector, to make things attractive for even simple things, they will only do that without other intervention, trying to engage and only for discussion. So
no, that's a problem of medical ethics. That
medical ethics, yes.
But what I'm saying is that somebody who is very much dependent on severely dependent on heroin is going to need.
They need, sir. That's fair. Very severe person to get him out of the risky behavior. That's a good strategy in a clinic. And I mean, we have analyzed our evidence at the NIMH. I think Dr. Saman Veeravathana, I don't know whether he's LinkedIn. He's running the clinic now, the substance use clinic. One of the main problems, even their spouses keep coming to our clinic, right? After the patients left, they said, sir, please give us something to give my husband. This guy is wasting all our money. He's stealing. He is causing havoc, right?
Yeah.
Just give some treatment. We'll make sure we can give it. But we didn't have anything. That is recorded in an MS clinic. And our attrition rate is 99%, like the dropout rate.
That is the problem.
Yeah, that is the problem. We don't have anything to offer.
That is the problem.
We delivered the psychosocial interest, only symptomatic treatment.
Why are we treating if it is 99%? Because we just have one encounter and the patient goes away and goes back to the college and starts using it. So then, I mean, if we want to have a solution to this, we need to have medication. Otherwise, we are just going to have this 99%.
That's right. Now the retention rate with
they're wasting our time and they're wasting their time as well.
That's true, sir. So the substance use clinic retention rate is better with alcohol and nicotine.
Yeah.
When compared to heroin, retention rate is very poor. Substance use clinic.
I'm sorry to interrupt this very interesting discussion. I'm just aware of the time. I think we have another session coming up. Is there any other?
Just final comment because I couldn't join in the discussion.
Of course.
Yeah. I had a few points to highlight. Otherwise, we are focusing on one particular area only. In this, I think the assessment is the key in anything when we are treating a patient. So we were talking about heroin withdrawal, but in anything, as I said, you need to look at all aspects and do a biopsychosocial. With that model, you need to assess the patient and find out what's happening. So in heroin withdrawal, you need to understand how we are going to assess the withdrawal symptoms. Just because the patient complains and reports, I mean, you need to look at the objectively evident, like pile erection, dilated tubules, and what you can actually observe, rhinorrhea, lacturia. and nasal eye discharge, So we can look at these things objectively and gauge the actual severity. So just not go by what the patient reports. So that's one thing I think we need to keep in our minds. And then prescribing tramadol and benzodiazepines, you need to slightly be careful of, because there are so many people who come just to get the prescription because they can sell it at a very high price in the black market. So you need to be aware of that. And symptomatically, helping our patients with antipsychotics or anything is perfectly accepted. And most of the time we help patients symptomatically, as Kapila mentioned, lots of risperidone was used in treating those patients rather than codeine. So that is the real truth. We have to improvise. We have to know that these medications are fairly safe and we are not giving them for long periods of time. So we need to be aware of practical aspects of assessing and managing patients. I think that's my contribution. Thank you for the want of time.
Thank you for that. And I think it would have been, I think we can continue, but in interest of time, we have to come to a close. So once again, can I say a very big thank you to our three eminent speakers for giving their time and expertise this evening, Dr. Anil Abesinghe, Dr. Mahesh Rajasurya, and Dr. Kapila Ranasinghe. Thank you very much. We really appreciate your contribution, and it was really interesting. And with that, we conclude this symposium. I shall now, Dr. Kadambanathan and I shall hand over to the organizing team for the next session. Thank you.
Thank you, Ellie.
Thank you.
Thank you, dear Mother. And also we would like another thanks for our esteemed speakers and chairpersons for being a part of that meaningful and comprehensive symposium. Our next session is going to be something very interesting and high education topics.
Exactly. It's going to be about our beautiful Austin, Trincomalee. One of our psychiatric team.
Sorry, I think we just lost you. We can't hear. Hello. The sound has gone off, I think.
Yes, Sumudu, is there any problem with your connection, or we can't see you or hear you?
Excuse me, Madam. Can you all hear us?
Yes, we can hear you now. Fine.
Yes,
may I ask whether you could hear what we said? Actually, my colleague and I made some statements, but could you hear, or should we have to?
No, we couldn't hear anything.
Okay, we shall repeat it again. Thanking our esteemed speakers and chairpersons for being a part of that meaningful and comprehensive symposium. Our next session is going to be something really interesting and out of our educational topics. Is it, Krishan?
Exactly. It's going to be about our beautiful Austin, Trincomalee. One of our psychiatric team colleagues, Dr. Isul Jayatilaka, medical officer in psychiatry, is going to show some beautiful features in Eastern Coast and other places of interest in and around Trincomalee.
Good evening, and on this special evening, I'll be briefing you on major tourist attractions in Trincomalee. And Trincomalee, which is situated in eastern province in the country, I have estimated population of about 431,000 population, and it is spread over 2,727 square kilometers. Trincomalee area consists of people belong to all ethnic groups in more or less in equal proportions in Sri Lanka, and Sri Lankan Moor being the largest in number. Moving on to the tourist attractions in Trincomalee, it consists of panoramic beaches, sacred religious places, and other places with historical importance, and most importantly, many places to enjoy your food. Starting from Pigeon Island National Park, which is situated approximately about 23 kilometers away from Trincomalee city, was established in 2003 and governed under Department of Wildlife Conservation. The Pigeon Island is used as a scuba diving site and an ideal place for snow. The pigeon, when considering the flora and the fauna in the island, more than 100 species of corals and 300 coral reef fishes are recorded. Among them, black-tick reef shark and several types of sea turtles are the most eye-catching. When you're visiting Pigeon Islands, make sure that you get to the destination early in the morning, preferably around 8 o'clock in the morning, in order to get the most stunning experience and in order to avoid possible sunburn. Next, Koneshwaran Temple, which is within walking distance from the town, is a Hindu pilgrimage, and it's being a tradition to visit the Kovil by every visitor to the city despite their religious background. Apart from Koneshwaran Temple, there are several sacred places scattered within the city. Sri Bhadrakali Amman Kovil, which is situated within the city, and the Salli Sri Muthukumari Amman Temple and Sri Lakshmi Narayana Perumal Kovil, also known as the Golden Temple, are situated within a couple of kilometers of the city. Tiriyaya Giriyandu Saya is also a known tourist destination, which is situated 47 kilometers away from the city, and it is believed to be the first Buddha stupa was built by Tapaswan Ballu. Seruvela's Mangala Raja Mahavihara is situated approximately 45 kilometers away from Trincomalee and built during the era of King Kavantissa, containing the Lalata Dhatun of Lord Buddha. On the way from Tiriyaya, you can visit Lankapatna Sri Samudragiri Vihare, which is also a sacred temple popular among local tourists. When you are traveling to these three places, make sure that you return before late night, because you may encounter wild elephants on the way, since both routes are traversing through the dense jungle. There are several beaches within close vicinity to the town. A few of them are Trincomalee Beach, Lavely Beach, considering the place. Considering the places with historical value, British War Cemetery, which is located approximately 6 kilometers away from the city and has graves of soldiers of British Empire who were killed or died during the World War II, and Dutch, French, Italian, and other allied forces. Adding to the list, you will be interested in Fort Frederick Trincomalee, Sri Lanka Navy Museum, Oz Hill Army Museum, which are all located in walking distance from the city. Kenya Hot Water Springs is another main tourist destination, which consists of 7 square-shaped wells having different temperatures in their water. Similarly, it's better you visit early in the morning to see the different temperatures in the wells and surely to avoid the crowd. And then, mouth-watering food in Trincomalee as a major tourist attraction. Traditional Indian food are easy to find here at any time of the day. If you are looking for seafood in Trincomalee, Trincomalee Fish Market is at the heart of the city, which will be opening around 3 a.m. in the morning, except public holidays. All kinds of seafood extending for many types of fish, crabs, prawns, and many more are available here. Furthermore, dry fish, which are famous among the country, are widely available in the city. Hence, if you are a seafood lover, Trincomalee is the ideal place to find your favorite seafood. Since most of the doctors are from Colombo, as you can see, it takes around 5.5 hours to travel from home by a private vehicle. And being far away from the family and loved ones, it's vital to balance your work and life. However, the smiles of people living far away from the cities have given doctors fuel to work hard, forgetting their hardships. Finally, we would like to invite you to visit Trincomalee and enjoy this amazing place where you will get unforgettable memories which will keep you in your heart forever, and keep it in your mind. It's better you can stay here for at least 4 to 5 nights to get the full tale of this glamorous environment. Thank you.
Thank you, Dr. Isuru, for your interesting presentation. With that, we shall move on to the next topic, which is challenges faced and benefits of being a regional psychiatrist in Sri Lanka. And this topic will be co-discussed by Dr. Sumudhu Godavitha, Consultant Psychiatrist, District General Hospital, Trincomalee, and Dr. Samira Dasanayaka, Consultant Psychiatrist, Base Hospital, Trincomalee. To introduce our speakers, I happily invite the Secretary of the Sri Lanka College of Psychiatrists, Consultant Psychiatrist, Dr. Chamara Vijayasinghe. The audience is over to you, sir.
Thank you very much. Now we come to a slightly different and very interesting session, which is a little less on the clinical and theoretical side, but possibly more important from a practical point of view for many young and not so young psychiatrists. Regional psychiatrists are the heartbeat of Sri Lankan psychiatry, and quite often serve the most needy of our population without much fanfare or recognition. Many of the trainees here will go on to be regional psychiatrists and continue the great work already done by their seniors. The Sri Lanka College of Psychiatrists is planning a mentoring program for young regional psychiatrists, having understood the crucial role you play in our mental health system. The speakers for this lecture on challenges faced by regional psychiatrists and how to overcome them and the benefits of being a regional psychiatrist are Dr. Sumudhu Godavitha, who is the live wire behind this webinar and has been the consultant psychiatrist at Trincomalee since 2019. Prior to this, she has been the psychiatrist at both Base Hospital Varakapola and Base Hospital Kalmune. So she has a lot of experience on what it is to be a regional psychiatrist. She has special interests in perinatal and community psychiatry and is the extremely energetic Assistant Secretary of the Sri Lanka College of Psychiatrists. The second speaker is Dr. Samira Dasanayaka, who is the Consultant Psychiatrist at Base Hospital Kantale since the start of the year. Prior to this, he was a psychiatrist at District General Hospital Ampara. A very active and popular figure in psychiatry circles, Samira has special interests in community psychiatry and emergency psychiatry. I'm certain this session will be extremely useful to the trainees, bring back fond memories to the seniors, and no doubt provide life lessons to all of us. Over to you, Sumudhu and Samira.
Thank you, Chamar, for your nice.
Good evening, everyone. It is my great pleasure to talk to you all today on this topic, challenges faced and benefits of being a regional psychiatrist in Sri Lanka.
The psychiatrists who work in peripheral areas are faced with many challenges. Long distance traveling, having to work far away from home, the service demand, and the dire need to improve the facilities are the main challenges that we faced.
Despite having many challenges, working in periphery as a psychiatrist is really rewarding.
It's not only us, but there have been several other psychiatrists who had worked in Trincomalee district, providing an immense service to the region over the years.
So we would like to extend our gratitude to our predecessors.
I can almost see it, that dream I'm dreaming, but there's a voice inside my head saying, you never reach it. Every step I'm taking, every move I make feels lost with no direction. My faith is shaking, but I gotta keep trying. I gotta keep my head high. It's always gonna be another mountain. I'm always gonna wanna make it move. Always gonna be an uphill battle. Sometimes we're gonna have to lose. Ain't about how fast I get there. Ain't about what's waiting on the other side. It's the climb. Keep on moving, keep climbing, keep the faith, baby. It's all about the climb.
Let me begin with some general information on the available mental health services in Trincomalee district. We conduct several clinics in our hospitals, including general adult psychiatric clinics, child psychiatric clinics, prison clinic, and prosopy.
We conduct 12 outreach clinics in the district. These are apart from the clinics that we conduct within the hospital. Lack of human resources have been the main obstacle for us to extend our services in the district.
Although we have been able to recruit some of the staff members with the help of the administrators, the number of MDT members in Trincomalee district is not adequate given the service demand.
For an example, at the moment, I don't have a nursing officer or a medical officer attached to our unit.
I have only 3 male nurses and 4 female nurses to do both ward work and community work. Moreover, we have only 1 occupational therapist for the whole hospital. We don't have psychiatry social workers or community psychiatry nurses. But I should thank the social workers and the counselors who are attached to DS office in Trincomalee for the support given throughout.
Inadequate infrastructure facilities and lack of awareness of mental health services are the main challenges that a regional psychiatrist would face. Although we face hardships, the job satisfaction and the sense of self-worth is very rewarding.
I would like to share 2 short videos of 2 of our nursing officers who would talk on their experience in developing infrastructure facilities.
I'm Naufran Valli, ward in charge, Chessuarana, DJs Trincomalee. The District General Hospital has the only mental health inpatient facility in Trincomalee district. It has been a great effort of the mental health to develop the service starting from scratch. The ward setting should be pleasant and comfortable for the patient with mental health issues. Renovation of the ward made a huge difference, and we believe that we have one of the best mental health unit in Sri Lanka at present. Our team has achieved many important service development goals, starting from the new reception area with 24 hours security officers. Now we have new seclusion room in female and male wards, new nurses station to improve the staff safety, new staff changing rooms, new ward round room with air conditioned facility, refurbished mother and baby unit with new attached bathroom. Most importantly, we have a mini theater with new ECT machine, room for family meetings, clinic areas with the activity room and the kitchen. We also have a separate area for child and adolescent patients. Thank you.
මානසික සෞඛ්‍ය තුළ සේව කරන ස්ටාෆ් විදියට අපිට එන සේවලාදීන් ඇග්‍රෙසිව් වෙලා ඉරිටබල් වෙලා තමයි අපිට සමහරවිට ප්‍රසන්ට් කරන්නේ. එතකොට අපිට ආරක්ෂාව ගැන අපි හිතන්න වෙනවා. ඒක අවස්ථාවක අපිට එක්ස්පීරියන්ස් එකක් ආවා. අපි බේසන් එකක බලන්න අපි බේසන් බලගෙන යනකොටම ටීයක් අරගෙන අපිට බය කරගෙන ආවා. අපි ඒ කාලේ අපි ඒකක තුල ජනරල් එක ඩිස්ක්‍රීට් දාලත් නැහැ. ස්පේෂන් ස්ටාෆ් සේෆ්ටි රූම් එකක් අදලත් නැහැ. එතකොට අපිට අපි ආරක්ෂා වෙනවා. අපි දුවලා ජනරල් වල එළියට පනින්න වුණා. පේෂන් අතුල දාලා එහෙම තමයි අපි ප්‍රශ්නෙට මුහුණ දුන්නේ. ඊට පස්සේ අපි ඒ එක්ස්පීරියන්ස් අරගෙන අපිට සේෆ්ටි ස්ටේෂන් එකක් ඕන කියලා තාවකාලික ලීබඩු වලින් හදලා සේවය කරගෙන හිටියා. කල් යනකොට ඒක පර්මනන්ට් විදියට අපිට අදලා දුන්නා. ඒ විදිහටම ජනරල් එකටම ස්කිල් දාලා දැන් patient safety එකක් තියෙනවා, staff safety තියෙනවා. එතකොට දැන් අපි සේවලාවින් සේව ලබා දෙනකොට අපි ඊට ඇතුලේ එනවා අපිට safety තියෙනවා කියලා හිතනවා. එතකොට මේ අපිට සේවය වඩා ලේසියෙන් දෙන්න අපිට පුළුවන් වෙලා තියෙනවා. අපි
The collaborative work with the administrators always help us to achieve our goals. Dr. Kyle Wali, Dr. Prem and Dr. Costa have supported us as the RDHSs in the Trincomalee region to improve the mental health services in the region.
Dr. Jagat Vikramaratna, the director of our hospital, will share his thoughts on leadership skills, teamwork, which help to provide the holistic care towards the patients.
As a medical administrator in a tertiary care hospital, I believe a regional consultant should have some important qualities to overcome the challenges in their working station. Good medical leadership is the key to build high quality health care. A good leader, manager will have the ability to think and conceptualize about abstract and complex situations concerning goals to be achieved, and ability to work well with people with sound knowledge and proficiency in his field to deliver the high quality health care. They will work with positive mindset, with adaptability, flexibility, with a new innovation, in a passionate manner till they achieve the goals. And they will sustain and disseminate the outcomes in order to develop the health system. Should they have good relationship with their team members? Years of as an administrator, I have witnessed this trend in this region.
Organizing awareness raising programs in the hospital as well as in the community is helpful for a regional psychiatrist. These programs help us to improve poor mental health literacy in the region as well.
Since 2019, in District General Hospital, Trincomalee, we have been arranging group discussions with other specialties in other units to discuss the relevant liaison psychiatry topics. For example, we discuss autism spectrum disorders with the pediatric team, psychological autopsy with the medical legal team, and the statistics that were collected after reveal that the number of referrals increased significantly following these awareness raising activities within the hospital. Let's listen to our senior consultant, pediatrician, Dr. Kamal Vikramasinghe's thoughts on psychiatry liaison work.
Mental health team in a hospital has a central role. This central role in the sense that they are not only treating the patients in the psychiatric ward, but they are extending their helping hand to the other specialties as well, like maybe pediatrics, maybe general medicine, maybe gyn-ops. This is what we call liaison psychiatry. Any illness, we cannot simply compartmentalize it as mental or physical illness because these two aspects always go hand in hand. For the holistic management, it is very important to address the psychological needs of the patient as well. We do value the support that we get from the mental health unit, but it is not only the patients, but we, the professionals, we also get some benefit. We can improve the professional relationship between the two teams, and we are also empowered with new knowledge. And finally, it's a very enjoyable experience to work the two teams together for a common goal.
Low mental health literacy in our district has led to an unfortunate consequence. In 2017 and 18, the highest number of maternal deaths were reported in Trincomalee district. There were 5 maternal suicides, including 3 were by hanging.
In 2018, once when the mental health team was carrying out the psychological autopsy of a mother who committed suicide by hanging, it has been revealed that the family members had found the infant on the floor, sucking the toe of the dead mother hanged in the roof. These types of striking stories push the mental health team to raise awareness of perinatal psychiatry in the region. The mental health team has been conducting several workshops to the primary healthcare workers since then. We have started a hotline number at MHU, a community network and a better referral system with the MOHs and PHs. We also have a sort of crisis intervention team where we do home visits at any time if we get to know an emergency situation in the community with regards to perinatal mental health problem. The community health staff, including MOHs and public health midwives, have been very vigilant on perinatal mental health issues over the last couple of years. And it gives me pleasure to mention that there were no maternal suicides in 2019 in Trincomalee district. Since 2019, up to now, only 1 maternal suicide was reported so far, which was in 2020 in Muttur, which is located about 38 kilometers away from the center.
Another challenge we would face is the language barrier. Nowhere is this more apparent than in the situation where the patient and the doctor are separated by a language barrier.
However, we have been able to carry out successful community workshops with the help of mental health nursing officers who have had 6 months psychiatric training at NIMH. Trying to overcome the language barrier with the help of the interpreters is again a challenge due to the time constraint, particularly when we do community workshops. To face this challenge, what we did was we carefully planned the program schedules beforehand, and we have received good feedback from the participants.
Although we have 1 acute inpatient facility in the Trincomalee district, the intermediate and long-term care of the patients in the district has been a challenge due to the lack of rehabilitation services and multidisciplinary services in the region.
The requirement of a medium stay rehabilitation unit in the district was identified about 8 to 9 years ago. As a result, the project to build up a medium stay unit was implemented with the help of the Japanese embassy. I take this opportunity to express my sincere gratitude to our sir, Dr. Jan Mendis and Dr. Prabhat Vikrama, and also the Sri Lanka College of Psychiatrists for their invaluable support in making this dream a reality.
In this COVID-19 pandemic, all the regional psychiatrists had to face the challenge of working in settings with minimum facilities to manage the COVID-positive individuals with psychiatric illnesses. Psychiatrists in the Eastern Province had several discussions about this problem, and we succeeded in opening a COVID unit at Trincomalee Hospital with 8 beds for male patients. With the help of the regional administrators, the Ministry of Health and Sri Lanka College of Psychiatrists.
The community mental health work in this COVID pandemic has been a huge challenge. Poverty, long travel distances, and shortage of public transportation during COVID-19 pandemic created potential obstacles for the patients to access mental health facilities. Let's listen to the doctors in mental health unit Trincomalee about how we face this challenge.
In 2020 March, when we faced the first COVID-19 wave, we stopped visiting outreach clinics within the community as well as the home visits. However, as a result, we experienced a mental health wave in mid-2020. Our wards became full. Once we had 200 bed occupancy in our female ward. Learning from that experience, we continued to do the home visits and outreach clinics during the COVID-19 second and third waves wearing PPEs. Our hospital admissions and defaulted rate did not rise like as in the first COVID-19 wave. Once when we were doing the home visits, our vehicle fell down into a paddy field. Although we were in PPEs, all the villagers came and helped us to pull up the vehicle. So that showed us that people were very thankful to us for our dedicated work during this pandemic.
Apart from that, we started telepsychiatry during COVID pandemic to maintain the mental health services without any interruption. We accessed the patient who were away from clinic via the Zoom. Furthermore, we have hotline, mental health hotline number which is active 24 hours, and we communicate the patient via emails too.
The privilege of being a true community resource and the ability to improve overall community mental health gives meaningful purpose to the work of regional psychiatrists.
I would like to share another interesting story with you all. In mental health unit Trincomalee, we hold monthly ward meetings. In such a meeting, once we were discussing the problems identified during home visits in an area facing lockdown restrictions. A junior nursing officer voiced her concerns of some patients' well-being. She said that there were families who were starving for days ever since lockdown restrictions were imposed in the area. She also said that there was one patient who received only the monthly injection apart from water after 3 days of starving. This story made us to start the charity work that you can see in the slides. We were surprised seeing the support and the donations that we received from our colleagues, the consultants in the hospital for the charitable endeavor. We delivered the food items to about 55 families of our patients.
Working in peripheral areas appears to be a disadvantage when we find it difficult to attend the CPD program arranged in Colombo. However, online meeting platforms introduced during the pandemic have been helpful for us when joining the lectures. Furthermore, having peer group discussion have helped us feel connected with our colleagues as well.
At the mental health unit, we discuss important topics that arise in certain times. Here in this slide, you can see that our senior nursing officer, Master Gaddafi, is presenting an interesting article on mental health nursing care. And also the District General Hospital Trincomalee receives students from the Eastern University. And it has been a privilege to have medical students, which creates an opportunity for us to keep our knowledge updated.
The students in Eastern University have opportunity to come to Trincomalee in our third year.
However, relocating to Trincomalee has been a challenge for most of us. The language barrier is an added stress for the medical student as well. But the mental health team in Trincomalee became a role model to us due to few reasons. Their team's unity, friendly manner, teaching sessions, and especially the end-appointment mocky. Mocky was the most rewarding aspect of clinical placement. It has been a challenge for the team to do the bedside assessment and the teaching together with the workload. But the time management in the team gave us the lesson that much of your personal and professional success depend on it. Punctuality, dress code, communication, honesty are the main areas that the team highlighted as important, apart from the subject matters when becoming a doctor. As a future doctors, I believe that the field of psychiatry requires more and more mental health doctors to improve the quality of life of patients as well as to fulfill services needed in the country.
Having a strong network of supportive family and friends helps to enhance our psychological well-being. We need people to turn for advice and encouragement whenever we face difficult times.
Relationships with the team members and the colleagues are the essence of life when we work far away from home. Over the period where Samir and I work in Eastern Province, our senior consultant, Dr. Gadambanathan, has been playing the role of a mentor to us. Over to you, sir.
Good evening to all of you. Thank you, Dr. Sumudhu, for the nice words and giving me this opportunity to speak a few words in this great event. I hope many in this forum agree with me that in low-resource settings, working as a team, supporting each other is the key to overcome the challenges and to preserve the team potential. These healing connections are the secret of success in self-progress as well as in service development. As a person who has been working in the Eastern Province just over a decade, it has been a great privilege to work with a consultant psychiatrist in the Eastern Province, and it is always a rewarding experience to witness their successes. Thank you, all of you, for providing me with these rejoicing moments. I take this opportunity to thank all my teachers and mentors who has been a tower of strength and guidance. Lastly, but not the least, my sincere gratitude to our college, the Sri Lanka College of Psychiatrists, for providing the opportunities to nurture these healing connections.
Thank you, sir.
I would like to conclude our presentation with this paragraph taken from a book published in July 2020 by Eddie Jaku, who is a Holocaust survivor. I had learned early in life that we are all part of a larger society and our work is our contribution to a free and safe life for all. If I went to a hospital and saw instruments that I had made and knew that they were being used every day to make life better, this gave me great happiness. The same is true of every job you do. Are you a teacher? You enrich the lives of young people every day. Are you a chef? Each meal you cook brings great pleasure into the world. Perhaps you do not love your job or you work with difficult people. You are still doing important things, contributing your own small piece to the world we live in. We must never forget this. Your efforts today will affect people you will never know. Thank you.
Thank you very much, Sumudhu and Samira, for that brilliant presentation. A lot of hard work has gone into it, and it was very interesting and enlightening. I wonder if anyone in the audience has any comments or questions for Sumudhu and Samira.
Tamara, can I start?
Yes, sir. You're most welcome.
Thank you, Sumudhu and Samira.
Hello, sir.
Yes, thank you for moving from traditional psychiatry to innovative psychiatry after identifying the real needs of the people you are dealing with, and along with an empathic understanding of the real needs and a pragmatic approach to cater to those needs. Thank you so much.
Thank you, sir.
Hi, Sumudhu and Samira and the team.
Hello, madam.
Hello, madam.
Hi. It's lovely. It's well done. Thank you for the beautiful presentation. We really miss coming to see you guys in person. And I was wondering whether we can swap workstations for maybe not for long, but at least for a short time. Beautiful. Thank you, guys. All the best. Right. Okay.
Thank you. Thank you very much, Sumudhu and Samira. That was very impressive and very interesting to listen to and watch your presentation. And thank you very much for your hard work. I'm sure quite a lot of hard work must have gone into that, and also the wonderful work that we have been doing both in Kantale and Trincomalee. And I think the most important thing is you're inspiring the junior psychiatrists who return from abroad, sometimes who complain all the time that they have to go to faraway places, and how interesting it is to work in faraway places, and what kind of work that you can do that you can cherish for your whole life and be very happy about it. I think you two have been an inspiration to all the young psychiatrists who sometimes stay on in Australia for greener pastures rather than coming back to our motherland. Thank you very much.
Thank you, sir.
And Samira.
Excuse me, I am Samira Ruanpriya, consultant psychiatrist from Monaragala. I have a question for Dr. Sumudhu and Dr. Samira. So you will be opening this Nilaveli Center very soon, no? So how you are planning to manage this center? Because I know that there are no consultant psychiatrists who will be appointed to that Nilaveli Center. So what is the plan for that?
Yes, ma. We are actually expecting a diploma holder in near future. Probably the person will go to the Nilaveli and oversee the work.
Yeah.
And while me and Dr. Sumudhu discuss how to provide the consultant service to the center, and we decided that alternatively we will go there and see our patients.
Hello, Sumudhu and Samira. I'm Amila.
Yes, hello. Yeah.
Hello. And it's truly inspirational, and the joy, the pleasure you enjoy by
Thank
working,
you.
and the courage is really infectious. I'm sure this courage and the pleasure of working will be infectious across the country, and so most of all us will be kind of work with a new strength, with your this kind of hope you have generated, and so you have kind of practically shown us with the minimum facilities what kind of things you can do to the community and the most deserved patient. Once again, congratulations, and really proud of you.
Thank you, Amila.
Right. Thank you very much. I'm sure there's many more people to comment and congratulate Sumudhu and Samira, but in the interest of time, and as we have a very interesting session conducted by our colleagues from the Trincomalee Clinical Society, we'll end this session thanking Sumudhu and Samira, and hope all of you stay on for this session done by the Trincomalee Clinical Society.
Thank you.
Thank you.
Thank you.
A big thank of gratitude to dear Madam and Sir. Our second symposium is based on the topic Interplay between Psychiatry and Medicine. To chair the symposium, once again, I would like to call upon Consultant Psychiatrist Dr. Sumudhu Kodavita and Consultant Psychiatrist Dr. Samira Senaik. Over to you, Sir and Madam.
Thank you, Krishan. First of all, on behalf of the Sri Lanka College of Psychiatrists, let me express my sincere gratitude to my dear colleagues, Dr. Dulmini Veeratunga, Dr. Kanchana Ramanayake, and Dr. Jevon Yudhishthran for accepting our invitation and agreeing to conduct this symposium, Interplay Between Psychiatry and Medicine. I also would like to say that it has always been a rewarding experience to work with you all in District General Hospital, Trincomalee. Dulmini. Now, let me briefly introduce my colleague and good friend, Dr. Dulmini Veeratunga, the consultant neurologist to the audience. She will talk to us on autoimmune encephalitis, the diagnostic dilemma for neurologists and psychiatrists, and there will be time for questions at the end of the presentation. Dr. Dulmini Veeratunga graduated from the Faculty of Medicine, Colombo, and she completed her 2-year senior registrar period in Teaching Hospital, Kalapitiya and National Hospital, Sri Lanka. She's the first consultant neurologist appointed to DGH Trincomalee. This is her first appointment as the acting consultant neurologist, and she's awaiting foreign training, which may happen next month, I think. And her special interest areas are epilepsy, neuroimaging, and cognitive neuroscience. Dulmini, over to you.
Yeah, thank you, Dr. Sumudu, kind introduction, and good evening, everybody. I would like to thank College of Psychiatrists and the Trincomalee Clinical Society for giving me this opportunity to talk about this very important and timely topic, autoimmune encephalitis and challenges we face when diagnosing the patient and treating. I'll show this slides. So, autoimmune encephalitis is a very important disease to consider because it is a disease with significant mortality and morbidity, but it's a treatable condition. With early treatment, mortality could be reduced up to 5 to 7% from 25%. And so it's a very important thing. And in addition to that, this is very important, this forum as well, because majority of these patients present with psychiatric symptoms. As an example, 95% of anti-NMDR encephalitis patients present with psychiatric symptoms. And also they have very low threshold for neuroleptic malignant syndrome as well. And also this is a relatively common disease, and it's becoming increasingly common. And you can see the case detection rate has increased over the last few years of the NMDR encephalitis. And according to the one community-based study, the prevalence of autoimmune encephalitis has even surpassed the prevalence of infective endocarditis. But this is one of the USA study. I think Sri Lanka still the infective endocarditis prevalence is higher than the autoimmune encephalitis. So as much as it's important, this is a very challenging condition. We face a lot of challenges when diagnosing these patients and treating these patients, and sometimes we face the overdiagnosis problem or diagnosis as well. So moving on to the first challenge, why it is often missed, because this is a relatively common new entity. The first described case of anti-NMDR encephalitis was published in 2007, and since then there are more than 10 new types have been identified, and also this is still an evolving entity. So there may be many possible unidentified manifestations of disease which go unnoticed. And also it has confusing symptomatology. They can present with neurological symptoms, psychiatric symptoms, and sometimes combination. And also there are some limitations in diagnostic criteria. The most of the diagnostic criteria included antibody testing or response to treatment, which none of which were not available at the beginning of the disease. So this delayed the treatment in initial period of the disease. So to overcome this, in 2016, Lancet Neurology has introduced the concept of possible autoimmune encephalitis and the stepwise diagnosis for this condition. So diagnostic criteria for possible autoimmune encephalitis, these patients should fulfill all of the following 3 criteria to diagnose. That is, first one is subacute onset, that is progression of symptoms within less than 3 months, which are working memory deficits or altered mental status, with at least one of the following symptoms. Those are new focal CNS findings, seizures not explained by previous non-seizure disorders, and CSF pleocytosis, that is WBC count in CSF more than 5 cells per cubic millimeter, and MRI features suggestive of encephalitis, with importantly with reasonable exclusion of alternative causes. And then we can move on to confirm the diagnosis of definitive autoimmune encephalitis and identify the specific types of autoimmune encephalitis as well by identifying specific clinical syndromes or detection of antibodies in the serum or CSF. The autoimmune antibodies can classify into 2 main categories according to the pathophysiology. First one is antibodies, where antibodies formed against cell surface proteins, which we call autoimmune encephalitis, and this is a topic of discussion today. The other type is antibodies against intracellular protein, which is almost always the paraneoplastic in origin, and it is irreversible. But unlike in that, the first type is reversible and treatable if identified early. So what is autoimmune encephalitis? It is an inflammatory brain disease where antibodies react against certain cell surface proteins, which cause subacute neuropsychiatric symptoms. But special thing is, unlike other autoimmune diseases, this condition has no systemic manifestations other than autonomic dysfunction. So, considering pathophysiology, autoantibodies are bind with the postsynaptic cell surface proteins and causing the functional block of these neurons and leading to the symptoms of autoimmune encephalitis. There are several types of autoantibodies involved, but in this presentation, I'm going to talk about the 3 types because these are the types with predominant early psychiatric manifestations. So I will be focusing on these 3 in the presentation. These are some rare types of autoimmune encephalitis. Starting with the most common type of autoimmune encephalitis, anti-NMDR encephalitis. This is predominantly seen in young females. 58% of these patients are associated with ovarian teratomas. There are certain other associated tumors as well, like breast tumors, endocrine pancreatic carcinomas, and so on. But children and males are less associated with tumors. Considering symptoms, there are 4 phases of the symptoms, 4 phases for this illness. First, they present with viral prodrome, and followed by mainly psychiatric manifestation. And at the peak, they will get neurological manifestations and take some time to reach the baseline, and they may left with some cognitive impairment as well. So 60% of these patients have prodromal period, which lasts less than 2 weeks usually, and they have fever, headache, and some subtle changes in attention, concentration, and speech during this period, and then followed by the early stage. Mainly in this stage, patients are presenting with psychiatric symptoms. 95% of the adult patients are presenting with psychiatric symptoms like agitation, aggression, disinhibited behavior, hallucination, and complex delusions. They may have subtle cognitive impairment as well. Then comes middle and late stage, where we can see steady decline in cognition and mental status of the patients, leading to fulminant catatonia and eventually coma. During this period, patient may get some neurological complications as well. Unlike in adults, children are usually predominantly present with neurological symptoms. According to one systematic review done among 464 patients with definite NMDR encephalitis, 68% of them were presented with behavioral abnormalities and similar number with psychosis, and 47% with mood disorders, and 30% with catatonia, and 21 with sleep disturbances. Many of these patients had combination of these symptoms, and modeling all the results, they have mentioned this as mixed psychosis syndrome. So neurological symptoms are quite late, there could be abnormal movements. One of the characteristic abnormal movement of the NMDR encephalitis is orofacial dyskinesia. I'll show a video again. And dystonic posturing, stereotypic movements, and choric-like movements. I'll show this video of this orofacial dyskinesia. You can see the abnormal movement around the mouth and face, including lips. So these are involuntary abnormal movements. So moving back to the symptoms, they can have 80% of these patients can have focal or generalized seizures, and they may have reduced level of consciousness and autonomic instability leading to hypoventilation and arrhythmias in late stages. I have shown this. They have inflammatory markers, usually normal or mild elevation, you can see, and basic metabolic profile usually normal. And CSF, there could be moderate CSF lymphocytic pleocytosis that is usually less than 100 cells per cubic millimeter, and some may have CSF polyclonal bands. But we should keep in mind the normal routine CSF studies do not simply exclude this antibody-mediated encephalitis. Then comes the EEG. 90% of these patients have non-specific slowing in EEG at some stage of the disease. It could be focal or hemispheric or diffuse background slowing. Only 30% of patients with anti-NMDR encephalitis have this characteristic extreme delta brush appearance in the EEG. In this EEG, you can see the EEG's background is generally slow. It's in the delta range, and the top of the delta wave, there are brush-like appearance that called extreme delta brush, which is characteristic for anti-NMDR encephalitis. MRI abnormalities only seen in only about 30% of patients, and that also non-specific. It could be a mild increased flare signals in cortical, subcortical, cerebellar, brainstem, or basal ganglia anywhere in the brain. So if a patient presents with above symptoms and fulfilling the criteria for possible probable autoimmune encephalitis, they can consider for probable anti-NMDR receptor encephalitis if they fulfilling following three criteria. First criteria is rapid onset of symptoms. 4 out of 6 following symptoms, those are abnormal psychiatric behavior or cognitive dysfunction, speech dysfunction, especially mutism and verbal reduction, seizures, and movement disorders, dyskinesia, rigidity, abnormal postures, and decreased level of consciousness, and also autonomic dysfunction or central hypoventilation. At least one of the following laboratory study also should be there. The abnormal EEG or CSF with pleocytosis or polyclonal bands with reasonable exclusion of other disorders. If the probable autoimmune anti-NMDA receptor encephalitis criteria are fulfilled, or considering that the definite anti-NMDR receptor encephalitis diagnosis could be made when the presence of 3 of the above 6 criteria accompanied by systemic teratoma, or presence of 1 or more criteria symptoms with detection of antibodies in the CSF after reasonable exclusion of the other disorders. So anti-NMDR receptor antibodies, we can detect the GLUN1 antibodies against GLUN1 subunit of the NMDR protein in CSF or in serum. This is to confirm the diagnosis, and the cell-based assay, we can do it in CSF or blood in the serum, but the serum cell-based assay usually less reliable because it can have false negative rate up to 14%. So antibody should be done in CSF to reduce the risk of false negatives or even false positives. And also antibodies concentration in the CSF correlates better with the clinical cause than in the CSF antibodies in serum. So moving on to the second type, that is limbic encephalitis. There are 3 types of limbic encephalitis. The first 2 types I'm going to discuss here. The most common type is the anti-LGI1 encephalitis. This predominantly occurs in males. In median age group is 60 years. The onset and progression is usually little slower than the NMDR receptor encephalitis, and only less than 5% are associated with cancers. They may have characteristic features, like most characteristic is basal-brachial dystonic seizures. And again, I'll show a video of this characteristic. You may see the abnormal movement and posturing in the face and upper limb, unilateral. Patient is conscious, aware, but patient can't control the movement. So that is facial-brachial dystonic seizures. So coming back to the characteristic features of LGI1 encephalitis, other movement disorders are like myoclonus, generalized seizures, and they can have 65% of these patients can have mild to moderate hyponatremia in the blood. And they also have psychiatric manifestations and memory impairment. In some cases, these facial-brachial dystonic seizures can precede other symptoms by many months. So they could have memory deficit. It could be short-term or long-term memory, and could be problems in working memory as well. And they also have early onset of psychiatric manifestations like confusion, psychosis, visual hallucinations, and personality changes. These usually followed by frank and focal neurological deficits such as hemiparalysis, aphasia, or ataxia. Later, they can have fulminant confusion, catatonia, coma, or seizures status. Investigations wise, these patients also have normal CRP, ASR, inflammatory markers, but 65% of these patients can have hyponatremia, and that is kind of characteristic for LGI1 encephalitis. And they have usually normal CSF findings, and antibodies could be detected against LGI1 and receptors in the serum or in CSF. Not like in NMDR encephalitis, these antibodies can be detected in serum or CSF. No difference. So EEG is usually normal in these patients. But in MRI, there are some characteristic features, increased flare signals in medial temporal lobes. You can see here the hyperintensity in the medial temporal lobes. And they have more rapid response treatment, especially facial-brachial dystonic seizures. The second type of limbic encephalitis is anti-AMPA receptor encephalitis. This is happening quite old age group. The median age is 56 years, but they present with symptoms similar to NMDR encephalitis. The other difference is they have MRI, specific MRI features like increased flare signals in medial temporal lobe, as I shown earlier. 50 to 60% of these patients may associated with tumors like lung, breast, or thymus. The third type is anti-GABA B encephalitis. I'm not going to discuss about this further because these patients are usually presenting with status epilepticus, seizures, and neurological manifestations. They can have psychiatric manifestations as well, but it's late. So if patients having this kind of symptoms, they can consider to diagnose definite autoimmune limbic encephalitis if all of the following 4 criteria are being met. The first one is subacute onset of working memory deficit, seizures, or psychiatric symptoms, suggesting involvement of the limbic system. The second one is bilateral brain abnormalities in T2 class MRI, highly restricted to the medial temporal lobes. Then at least one of the following: CSF leocytosis or EEG with epileptic or slow wave activity involving only in the temporal lobes bilaterally, with reasonable exclusion of the alternative curves. But if one of the above first three criteria is not met, but still we can diagnose the definite autoimmune limbic encephalitis by detecting specific antibodies in the serum or CSF. Next three types of autoimmune encephalitis are usually they present with neurological manifestations, so I'm not going to discuss further about these types, but I'll leave the slides if anybody interested can go through them later. The anti-DDPX antibody encephalitis and anti-Caspar-2 encephalitis. This is a summary of all of the encephalitis. So, if the patient is eligible for probable autoimmune encephalitis, but all of their antibodies are negative, still we can diagnose and treat them with antibody negative but probable autoimmune encephalitis. They should fulfill all of the following criteria, that is rapid progression, rapid onset, working memory deficit, altered mental status and psychiatric symptoms, as we know. Now, exclusion of well-defined syndromes of autoimmune encephalitis, like typical limbic encephalitis, Bicester encephalitis, and other encephalitis types, and absence of well-characterized autoantibodies in serum and CSF, and at least two of the following criteria. Those are MR abnormalities suggestive of autoimmune encephalitis, CSF leukocytosis or oligoclonal bands, and brain biopsy, if you do, showing inflammatory infiltrates and excluding other disorders, with reasonable exclusion of alternative causes again. So with this, we can move on to the treatments. The important part, treatment largely depend on expert opinion and retrospective case series, because as this is a new entity, there are no randomized controlled trial and higher level of evidence. So in acute stage, we should treat with immunotherapy as soon as possible. That is with corticosteroids, usually IV methylprednisolone, 1 gram daily for 3 days, with IV immunoglobulin or plasma exchange. For certain refractory cases, we can consider cyclophosphamide, rituximab, or obexelimab, or tocilizumab. Then the other important modality is removal of the immunological trigger, that is the removal of tumor if there are any tumors, and also supportive therapy for psychiatric symptoms, movement disorders, seizures, and those things. And they should that should followed by maintenance therapy. The duration of maintenance therapy is no consensus for that, and what usually do is minimum of 6 months. We have to give steroids with steroid sparing agents like MMF or cyclophosphamide, aspirin. That could go up to many years according to the patient, and there's a chance of relapse. Then the rate of relapse vary from 12 to 35%, and usually happen when we are tearing off the immunotherapy. Considering the anti-NMDR encephalitis again, that has a fairly good response to immunotherapy if we start early. And the first symptom to recover is autonomic symptoms and respiratory functions, and then the movement abnormalities and seizures. And cognitive and psychiatric symptoms are the last to improve. Some may left with residual symptoms of memory and cognitive impairment, even after many years of treatment. So they need long-term treatment with steroids and steroid-sparing agents like MMF or therapy. And periodic screening of an ovarian teratoma should be done at least for 2 years. 53% of these patients will clinically improve within 4 weeks of treatment. But the relapse rate for anti-NMDR encephalitis is 20 to 25%. And they may need many months of treatment to reach the full effect. So with this slow response comes a second challenge. That it takes many months to recover these patients, and mean duration of hospitalization is 3 to 4 months. So with this, we get pressure from the family and the hospital staff. We should change the diagnosis. So we need to change the medication or something like that. But we have to be very confident to continue treatment, knowing that this is very slowly responsive disease. And at the end of when they can have some residual symptoms as well. The third challenge is overdiagnosis. This is, I think this is mainly because of the recent enthusiasm of clinicians about this new entity. And also there are many mimics of this condition. So what are these mimics? Mimics are infections, especially herpes simplex virus infection, encephalitis, and metabolic encephalopathies, Hashimoto's encephalitis, CJD, ADEM, and bigger stuff encephalitis. And also substance abuse and some primary psychiatric disorders. Out of these mimics, I will explain briefly explain two important mimics. One is herpes simplex virus encephalitis, because 20% of these patients can develop autoimmune encephalitis after some time. They can manifest with new onset choreathrosis or psychiatric symptoms few weeks after or even few months after the viral infection. If a patient presents like this, we should consider the two diagnoses in these patients, whether it is viral encephalitis relapse or autoimmune encephalitis. We should differentiate this clearly because the treatment is totally different. Viral encephalitis, we have treated antivirals, acyclovir, and autoimmune encephalitis immunosuppressants. So if a patient comes with these symptoms after the diagnosis of HSV encephalitis, should do CSF studies, CSF viral studies especially. If the viral study is positive, we can diagnose them as a viral encephalitis relapse. But if it is negative with or without anti-NMDR encephalitis, we should consider autoimmune encephalitis. In addition to the anti-NMDR encephalitis, they can have, rarely they can get GABA receptor encephalitis or dopamine receptor encephalitis. So the other important mimic is Hashimoto's encephalitis. That is also immunomediated disease with good response to steroids. They also can present with psychiatric manifestations, movement disorders, myoclonus, hallucinations, stroke-like episodes, and they may have overdose subclinical thyroid disease. If a patient like this came, we have to do antibodies, thyroid peroxidase or thyroglobulin antibodies, and start steroid as soon as possible to treat the condition. So those are the important mimics. So let's see when it is less likely to be autoimmune encephalitis, patients coming with these symptoms. If it is very acute onset, within days or weeks, and if patient is having significant signs of meningism like neck stiffness, photophobia, severe headache, and those things, more suggestive of infections, and high probability psychiatric illness like family history, precipitants, substance abuse, those things, and patient may come in with pseudoseizures as well. We should keep in mind even if the serum studies for anti-NMDR is positive for these kind of patients, 19% of schizophrenia patients and 3% of healthy individuals can have positive NMDR antibodies in serum, but not in the CSF. So, I'm going to end this presentation by highlighting these few important things. In a patient with psychiatric symptoms, when to suspect autoimmune encephalitis, what are the red flags? New onset rapidly progressing psychosis, seizures, dyskinesia, focal neurological signs, and dysautonomia. And we should check the pulse and the blood pressure regularly for these patients to detect autonomic dysfunctions, and prominent headache or flu-like illness, new onset catatonia or rapid progression to catatonia without other psychiatric manifestations, mainly cognitive deficit that appear out of proportion to the duration of psychiatric illness, and refractory psychosis and associated EEG abnormalities in patient with recent history of HSV encephalitis or diagnosed patient with malignancies. If patient have these kind of red flags, should proceed with investigations like basic investigations and careful observation for abnormal movements, seizures, and abnormal behaviors and those things. And CSF studies, if possible, with electronic bands, and EEG imaging, particularly MRI, and should consider for early treatment and then the definitive diagnosis. So the important take-home messages of this presentation are antibody-mediated encephalitis should be suspected in any patients with new onset psychiatric symptoms, and we should be vigilant to detect those subtle features of autoimmune encephalitis. And poorly defined syndromes with no antibodies can be regarded as probable autoimmune encephalitis and proceed with the treatment. The absence of leukocytosis does not rule out autoimmune encephalitis, and autoimmune encephalitis can occur with normal or atypical MRI findings. There are several mimics of autoimmune encephalitis. Some respond to steroids, some are not. And treatment should start as early as possible, and they may need long period of ICU care or inward treatment. They should undergo appropriate cancer screening according to the type of autoimmune encephalitis. And they could have some residual symptoms again, and they can relapse. So these are the important messages that I want to show you regarding this disease. And early treatment is the life-saving method to do that. We should be vigilant to detect some features of autoimmune encephalitis in patients presenting with psychiatric symptoms. So these are my references. Thank you for listening.
Okay, thank you, Dulmini, for the informative presentation. Now the floor is open for questions, comments, and discussion. Dulmini, can I have a question? Yeah. How is your experience here in the local settings? Have you seen those patients?
Yeah, local setting, actually it's quite common condition. I have seen for my 3 years period, I have seen about 20 patients of autoimmune encephalitis, mainly anti-NMDR encephalitis. Some are antibodies positive and some are negative. And the response to treatment, if we detect early, we usually start the treatment with IV, methylprednisolone and immunoglobulin both together, and they respond well. The patient with positive antibodies respond better than the patients with negative antibodies. And most of them are functioning well after a few years after they are in a normal routine.
Thank you. Anyone has any questions? In the absence of any further questions, we would like to conclude the presentation, and we will be moving to the next presentation.
Thank you, Dulmini, for the enlightening presentation. Now we'll have the presentation by Dr. Kanchana Ramanayaka. I'm pleased to welcome Dr. Kanchana Ramanayaka to the symposium. Dr. Kanchana Ramanayaka is the consultant radiologist in District General Hospital, Trincomalee. He graduated from the Faculty of Medicine with second-class honors. And Dr. Kanchana Ramanayaka has worked as an acting consultant in District General Hospital, Ampara for 2.5 years, and also 6 months in Base Hospital, BBS. He had his foreign training in Kingsmill Hospital, Sherwood Hospital, Trust, UK. Since January 2021, he has been working as a consultant radiologist in DGH Trincomalee. Now I will pass the audience over to my colleague. Please join me in welcoming Dr. Kanchana Ramanayaka. Kanchana?
Yeah, thank you very much, Sumudu. for the
Hello.
introduction and for inviting me on this lecture. Today my lecture is on today my lecture is on case-based discussion on neuroimaging in psychiatry. So as you all know, this is a kind of interactive lecture, so it is not easy to do through the online because we need, if you actively participate, it is easy to do, but anyway we can't help, we have to do it in online. So I would be grateful if you can actively participate, then it is easy to do the lecture. And also I am having a little experience in psychiatry because after my faculty life, I have never worked in a psychiatry unit, so please don't ask a question in the psychiatry part. Actually, from these cases, most of the cases were taken during my foreign training, so most of the cases are from UK, and only few cases taken from Trincomalee. So we will move to the first case. This is the first case. 40 years old male patient, is a homeless patient, found wandering in the road. So obviously detailed history is not available. He had poor hygiene with bad odor, and he was restless, not sitting on a chair, even with the repeated request. So there, he had poor eye contact, so not followed any verbal or non-verbal commands. So the patient was admitted to the ward. So during the inpatient evaluation, patient remained withdrawn and completely absence of speech. He didn't have any concern for foods and self-care. He slept only 3 to 4 hours. But when he was not sleeping, he just wandered in the ward. So during examination, it was unremarkable except mild pallor. So what is the possible diagnosis, I mean, in the psychiatric point of view? Anyone would like to contribute? So anyway, they have made the diagnosis of undifferentiated schizophrenia. So they have started drugs, that is risperidone and benzexol. Then patient develop extrapyramidal side effects. So they have increased benzexol and risperidone stopped. Then they have started olanzapine. But the clinical condition of the patient did not improve, and he developed extrapyramidal side effects. They were persistent, so they have suspected some organic causes, and they have done a non-contrast CT brain. So this is the non-contrast CT brain. So can anyone tell me what are the abnormalities? There's another cut, yes. So can anybody see any abnormalities? Because I can see 2 abnormalities. Any guesses?
Yeah, just a guess. I'm
So there
Devasmita
is
here.
cerebral edema.
Edema.
Yes,
I also think
yes,
cerebral edema.
exactly.
Yeah.
Exactly. Cerebral edema is there. In addition to that, there is a very subtle abnormality. I think it is difficult to pick. But as you said, they also have detected the cerebral edema, and after that, they have done contrast CT to find the cause for the cerebral edema. So now can you see another abnormality? I think now it is seen more clearly.
Is it a subarachnoid hemorrhage?
Yeah, exactly.
Yeah. Mm.
Not subdural, actually. It is a subacute SDH. You can see there are two lines.
Mm.
Beyond that line, there is a homogeneously isodense area. That is subacute subdural hemorrhage. So if we go back to this slide, again you can see there is a faint line here, and there's another line here with a little bit of active bleeding also. That is very subtle.
Kanchana, I'm Devasmita, psychiatrist from Peradeniya Hospital.
Yeah.
If I may ask, in the history, it was not mentioned how long was the symptoms.
Yeah, the thing is, the detailed history was not available because the patient
okay,
just
yes.
wandered in the
Right,
road and like that. So I think most
Yeah,
likely a few days or few weeks should
Yeah,
be.
yeah, that's right. Yeah.
Yeah. So after that, they have done the hematoma evacuation by Burhole, and first setting patient improved in his speech and emotional response, everything. So this is the second case, 52 years female patient with 20 years of history of schizophrenia. She was on olanzapine 20 milligram daily, presented with newly onset of persecutory delusions, disorganized speech, reduced appetite, and suicidal ideation over 2 weeks. Then they have started clozapine started, but with the 5 days of medication, the patient experienced dizziness and episode of convulsion, followed by expressive aphasia. So due to the expressive aphasia, they have requested non-contrast CT brain to exclude any organic causes. So this is the non-contrast CT. So there are obvious so many abnormalities. So can please anyone contribute?
I think there is midline shift.
Yeah,
And then
exactly.
cerebral edema.
Yeah, exactly. Exactly. There is an obvious midline shift. And you can see the lateral ventricle is compressed, and right lateral ventricle posterior horn is dilated. Cerebral edema is there. In addition to that, there is a subtle change, that is when comparing with the bone, this side there is a slight hyperestosis of the left frontal bone. So anyway, there should be a mass lesion somewhere here. So after that, they have done the contrast CT. This is the contrast CT. So it is obvious the diagnosis. That is a meningioma. This is avidly enhancing mass lesion, extraaxial mass lesion. So that's why I told there's bone hyperestosis, because it is a characteristic feature of a meningioma associated adjacent bone hyperestosis. So this is the MRI. There's a nicely seen contrast enhancing extraaxial mass lesion, that is meningioma. So this is a very interesting case. Actually, this was recently encountered in our hospital about 1 month back. 64 years male patient who is non-patient with chronic renal failure, that means he is an immunocompromised patient, presented with neck pain for 2 to 3 weeks. The patient initially admitted to the surgical ward and they have managed symptomatically and they have discharged the patient, and after discharging, after 3 days of discharge, patient developed psychotic symptoms, that is delusion of persecution. He strongly believed people were trying to harm him, and he had the delusion of infidelity, that is he believed his wife is having extramarital affair. So due to that, he had attempted suicide, killing his wife several times. So due to these symptoms, his relatives brought the patient to the hospital, and after patient admitted to the ward, the patient later patient became drowsy and reduced level of consciousness. So due to that, they have requested the CT brain and cervical spine. So this is the CT brain. Actually, there is nothing much except the age-related cerebral atrophy. This is the CT cervical spine, sagittal view, and this is the axial view. So, can anyone see any abnormality? There are some degenerative changes. Please ignore those changes. But there is a single important change. Actually, it is also a bit subtle change, but can you appreciate that there is a small erosion in the odontoid process with some sclerotic line, and in the axial section, this is the erosion, and there are calcific densities also around the odontoid process. So the differential diagnosis for the odontoid, there are so many differential diagnoses for the odontoid process erosion, but with the clinical features of the patient, one possibility is the CPPD, that is calcium pyrophosphate deposition disease. It is also common in renal patients, and especially he is a male. Another thing is infective TB or bacterial. So due to these differential diagnoses, they have done the CSF analysis, and it was supportive for TB meningoencephalitis. After that, anti-TB drugs was started, and about, I think, 1 week later, patient was improved. This is the fourth case. 90 years old female patient presented with features of acute psychosis for 5 days. That is irrelevant talking, hallucination, aggressive and violent behavior. She had a history of depression, but no records available and was not on treatment. She didn't have any fever, vomiting, headache or fits. So examination, including CNS system, was normal. CSF analysis also was within normal limit. Anyway, they have done a CT to exclude organic cause. So this is the CT of this patient. Actually, the abnormalities are very subtle. So can anyone see any abnormalities? And I am sorry, the images are also not very clear. But anyway, we can appreciate that when we compare in the temporal horns of lateral ventricles, the right side lateral ventricle is smaller, and there are some subtle hypodensities in the medial part of the temporal lobe, right temporal lobe, in comparing to the right side, left side. So then they have done the MRI. So in the MRI, the abnormalities are very clear. That is hypersignal intensities in the medial temporal lobe with mass effect on the temporal horn, and high signal intensity in the insular cortex. There are some other changes also that is due to the periventricular ischemic changes as she is 90 years old. So I think now you can come to a diagnosis. Changes in the medial temporal lobe and insular cortex. Because I think in the previous lecture, Dulmini has mentioned some diseases. Yeah, that is diagnosis of HSV encephalitis. So usually in the HSV encephalitis, changes are bilateral, asymmetrical, or unilateral. Usually changes are seen in the medial temporal lobe, insular cortex, and limbic system. Here the difference is was previously Dulmini mentioned that in the autoimmune encephalitis also the changes we can see in the temporal lobes and the insular cortex and limbic system. But the thing is, in usually HSV encephalitis, it spares basal ganglia. This is my final case. 27 years female patient presented to the OPD with spells of crying, laughing without any reason, and aggressive behavior for 3 years. Few episodes of symptom free. Then she was referred to a psychiatrist, and they have made the diagnosis of cluster B personality traits. Don't ask about that. I don't know. I don't have any idea. But after that, some medicines and cognitive therapy started. But patient didn't improve, and 4 months later, she developed progressive and painful weakness of right lower limb. In the next 3 months, she could not do daily routine, and she was almost bedridden. Then after that, she was admitted during CNS examination. It was abnormal with reduced power in the right limbs and reduced sensation and some cranial nerve abnormalities. So due to that, they have done the MRI. This is the MRI, and the changes are obvious. There are so many high signal intensities. So can anybody tell me the diagnosis?
Multiple sclerosis?
Yes, exactly. It is a multiple sclerosis. There are juxtacortical, periventricular, insular cortex, but here the only thing is corpus callosum is spared. In the temporal lobes, brain stem, that is primary progressive multiple sclerosis. So typically the lesions are seen in the periventricular white matter, corpus callosum, temporal lobe, brain stem, cerebral, and spinal cord. Okay, thank you so much.
Thank you, Kanchana, for very interesting and very informative case discussions. If anyone got questions, now the time for that. Looks like that there are no questions. So thank you, Kanchana. We will be moving to the next topic.
Okay, thank you.
Thank you, Kanchana.
Thank you, Sindhu.
Now, let's move on to the last lecture of this symposium by the consultant physician in District General Hospital, Trincomalee, Dr. Jevon Yudhishthran. He's going to talk to us the interplay between neurology and psychiatry. I really appreciate your presence here today with us, despite your busy schedule due to the upsurge of COVID-19 crisis. Jevon, let me briefly introduce you to the audience. Dr. Jevon Yudhishthran graduated from the University of Colombo. He was board certified as a consultant physician in 2015. Dr. Jevon is a fellow of the Royal College of Physicians, Edinburgh, and also a fellow of the American College of Physicians. He has worked as a resident physician in Jaffna in 2016, and he was the consultant physician in DGH Kilinochchi from 2017 to 2020. Since mid-2020, he has been working as a consultant physician in DGH Trincomalee. And he has about 12 publications and a case series. Okay, over to you.
Thank you for the introduction, Sumudhu. I would like to thank Sri Lanka College of Psychiatrists for inviting me to do this lecture. So I would like to do the lecture on the interplay between the neurology and psychiatry in seizure disorders. Seizures are due to uncontrolled, hypersynchronous, excessive neuronal activity. So the presentation will depend on which part of the brain is affected predominantly, as well as which part of the brain is affected primarily, as in what is initially starting off before it becomes generalized. So for the purpose of this particular talk, it is divided into two categories, provoked and unprovoked. Actually, seizure categorization is much more complicated. Provoked seizures are due to some underlying insult to the brain, infection, neoplasm, bleed, trauma, alcohol withdrawal, and such. Unprovoked seizures are where you don't have a clear etiology. So, for definition, to diagnose epilepsy, we need two unprovoked seizures. Okay. So you need two unprovoked seizures to make a diagnosis of epilepsy, just for context. So there is a high rate of psychiatric comorbidities predating seizure onset in epileptic patients. Furthermore, as you will see in the following slides, there can be psychiatric complications which occur after the diagnosis of seizure in epileptic patients as well. So this taken together suggests that there is a bidirectional relationship and most likely a common underlying mechanism for psychiatric disorders and epilepsy. Psychiatric comorbidity occurs in about 20 to 40% of patients with epilepsy, and there's a higher incidence in treatment-resistant epilepsy and temporal lobe epilepsy. The justification or the reasons will come later on. About 5 to 20% of patients attending epilepsy clinics show evidence of functional non-epileptic attacks. Just for some context, I'd like to say patient may have a functional non-epileptic attack, as well as patient may have a coincident epileptic disorder as well. For example, when I was in Kilnochi, there was a patient whom we treated overnight for status epilepticus. So from 6 o'clock in the evening, we went from first tier, second tier, third tier anti-epileptic drugs, finally going up to the level of midazolam to continue status, to control the status epilepticus. At about 1 o'clock, 2 o'clock, we got the status under control. Then we kept the patient. She woke up in the morning. And when I went for the morning ward round, the patient demonstrated a non-epileptiform seizure. So just to keep an idea, just because we find a non-epileptiform seizure does not exclude a diagnosis of epilepsy. The majority of psychopathology of epilepsy, the majority of patients with well-controlled epilepsy do not show psychopathology. However, a subset do. So the risk factors for this include poorly controlled seizures, a longer duration of seizure disorder, especially with onset in childhood, seizure focus in the temporal lobe, bilateral or multiple discharges on each, and structural lesions. As you see in the next slide, when the onset is in childhood, this is likely to affect the development of personality, social functioning, and coping responses. And when it is near the temporal lobe epilepsy, it is close to the limbic system, so which plays a major role in emotions, memory, and arousal. There is a higher suicide risk in patients with epilepsy. And suicidal ideation can occur as part of an interictal mood disorder or post-ictal symptomatology. Interictal disorders occur not during a seizure ictal period or in the post-seizure period, rather in between the seizure episodes. The post-ictal period is immediately following a seizure disorder, the seizure episode. The risk of suicide is elevated in patients with and without known psychiatric comorbidity. So the risk factors for these include male gender, temporal lobe epilepsy, and a higher seizure frequency. The incidence of psychotic disorders is also 2 to 3-fold higher in patients with epilepsy. So again, the same type of explanation. The psychotic disorders may be due to the epilepsy itself. It's interictal psychosis 34%, post-ictal psychosis 26%, according to the study which is mentioned at the end of the slide. Or there may be a comorbid primary psychiatric condition such as schizophrenia. You can also have psychosis secondary to anti-epileptic drugs. So again, the post-ictal psychosis occurs within 24 to 36 hours following a seizure episode and will recover over days or weeks. Interictal psychosis will usually occur in between seizure episodes where the patient is generally lucid. That also has chronic and intermittent presentations. The chronic presentation may have a confusion with schizophrenia. In psychosis secondary to anti-epileptic drugs, some of the drugs which have an effect, levetiracetam is the most associated drug in psychosis. Other drugs, topiramate, lamotrigine. Both valproate and carbamazepine have some protective effect. So patients with temporal lobe epilepsy are at increased risk of post-ictal psychosis. The reasons, as I explained above, with the connection with the limbic system. Post-ictal psychosis begins within 48 to 72 hours of a seizure following a lucid interval and then improves over days or weeks. Post-ictal psychosis is associated with positive symptoms including paranoid or referential delusions, hallucinations, and aggressions. This is a little beyond my level. This is data I found. Temporal lobe epilepsy makes up a disproportionate proportion of numbers with interictal psychosis, but the relationship here is weaker. Interictal psychosis may be more likely to manifest with disorganization and negative symptoms. So the question which comes about is the patient who presents abnormal movements and reduced consciousness actually having an epileptic seizure? Or whether it is representing a non-epileptic paroxysmal event, which includes psychogenic non-epileptiform seizure. Another condition which can manifest like this, a medical cause, is when they have a syncopal or pre-syncopal episode where the blood supply to the brain is interrupted temporarily, where they again manifest a seizure-like disorder. So psychogenic non-epileptiform seizures are not associated with abnormal excessive neuronal activity. So there are historical terms which we still use, pseudo seizures, hysterical seizures out of habit, but they are now disparaged. It is important to recognize these psychogenic non-epileptic seizures as they are usually over-treated with anti-seizure drugs due to perceived resistance. They are most likely to overutilize as well as waste healthcare resources, have an adverse iatrogenic effects due to drugs, and have worse outcome due to delayed psychological treatment. So it's important to recognize these conditions early. Among patients referred to outpatient, about 25% are felt to have psychogenic non-epileptic seizure, and while 25 to 40% of patients evaluated in inpatient epilepsy monitoring units have intractable seizures are diagnosed for psychogenic non-epileptic seizures. There is a strong female predominance here, 66.99% on one particular study, and more commonly to present in the third decade of life. Most psychogenic seizures, non-epileptic are dissociative of conversion disorders. So one of the ways of recognizing this is with a proper history. Precipitants and circumstances. Number 2 is a description of the ictus, the seizure episode. What are the post-ictal symptoms? How it comes on, how it resolves, what are the symptoms, and how is the response to treatment? So most episodes of psychogenic occur in front of witnesses. So an episode in the doctor's waiting room or examination room was estimated to have a 75% predictive value for psychogenic non-epileptic seizures. Similarly, in a study of patients with EEG, when episodes occurred at the time of electrode placement, were found to be psychogenic non-epileptic seizures. There was a habit those days, I don't know whether it is still practiced, when we were at medical officer level, where sometimes when you give them a tablet and say that this might induce a seizure, you could get an onset of seizure in these patients. Due to, of course, that there are many confounding factors, I don't think it's no longer practiced these days. We can observe this video. So this is again an example of a patient having a psychogenic seizure in the doctor's waiting room. You will notice from the movements, which we will come to later, they are very haphazard. Both legs moving at different times, both arms moving at different times. His eyes are open. The patient is conscious. These videos.
Don't do it. Ask him to do it.
Right, and following the seizure, his recovery also will be rapid, which is again another indicating factor. This is the arching of the back of his opisthotronus. Again, a typical feature of psychogenic seizure. We will come to this also later.
Call him by his name. Try to call him. Ask him to raise his hand, right hand up. Don't do it. Ask him to do it.
So this is actually a very obvious case.
Just say left hand up.
These videos have been lifted from YouTube, so they are rather easy to find if you actually type in psychogenic non-epileptic seizures.
Okay. Right leg up. Okay. Other leg. Ask his name. What is your name? Oh, okay.
Go to the next slide. Okay, psychogenic non-epileptic seizures tend not to occur during sleep. By contrast, epileptic seizures can occur during sleep. And some forms of epilepsy, nocturnal epileptic episodes, are much more frequent. Some epilepsy syndromes associate dramatic bizarre movements. This is applicable to frontal lobe epilepsy, where they have a very bizarre movement disorder. Sometimes it is mistaken for psychogenic non-PNES. So that is something we have to be aware of. Right. Stress usually induces psychogenic non-epileptic seizure. However, it is also a common precipitant for patients with epilepsy. But the witnesses is more likely to say that the patient was associate emotional stress or trigger when it is psychogenic non-epileptic seizure. Increased seizure frequency during perimenstrual time period suggests an epileptic seizure. So PNES, again, unresponsive behavior with motor manifestations mimicking a GTC, generalized tonic-clonic seizure, or a focal seizure with impaired awareness is the most common manifestation. That is because this is the most common dramatized manifestation that most patients have seen. Some clinical behaviors may occur during PNES, which are used to differentiate, distinguishing them from epilepsy. So the longer duration, usually seizures, epilepsy, GTC, is a very short duration, 30 seconds to 1 minute, unless it goes into status. A fluctuating pose goes up and down, again, which is very unusual for actual epilepsy or seizure disorder. Asynchronous movements, pelvic thrusting. We'll come have a video of that also later on. Side to side head movements or body movements. Ictal eye closure, they keep their eyes tightly closed. Or when you try to open them, the eye rolls up. Ictal crying, memory recall. After the seizure, they have a recollection of what happened. Or absent post-ictal confusion. Unless, as I mentioned in the previous slide, unless they are familiar with epilepsy in the family, or through other means, manifestation will mirror the preconceptions that they hold. GTC recovery. So usually as medical professionals, we can differentiate seizure based on what we see, because they will not be able to mimic a perfect seizure most of the time. GTC recovery is usually about 30 minutes to a few hours. Temporal lobe epilepsy can recover within a few minutes. That has to be kept in mind. But you will see most of these patients, they recover within a few seconds. It is difficult to mimic post-ictal drowsiness and reduce responsiveness. As I mentioned earlier, specific movements, writhing, thrashing, pelvic thrusts, opisthotonus, arch-back, which we saw in that patient, jacutation, which is rolling from side to side, suggest PNES, but these are not always present. Frontal lobe epileptic seizure again can produce a very unusual appearing seizure, so that is something to keep aware when there is a doubt about the diagnosis.
And these are two videos that I usually show. I don't know if we'll be able to see it now.
So this is a patient who is going to have a typical seizure.
Eyes are
This is probably a secondary generalized event. First off, he's starting off staring into space. He'll put his paper down. It will then become secondarily generalized.
staring.
Go into a tonic phase. The video is a bit slow due to the internet connection, however, here this is going into the
tonic
phase.
Someone saw it.
Where all the muscles become
They said, actually, that's good, isn't it?
Seizure contractions and both the tonic and the clonic phase are violent, which is one of the ways you can differentiate actual tonic-clonic seizures from patients who are having PNES. They cannot mimic this degree of violent contractions or muscle rigidity. If you actually feel a patient who is having a seizure, muscles will drop hard.
Fitting, and you can see the rhythmic movements.
So this would be the tonic phase. Then within a few seconds, he goes into the clonic phase.
My quite rhythmical, you know, tune, it happen. Yeah.
I'm going to forward it a bit to another patient.
It's complex. Someone may have said, "Can
This
you?"
is another patient who is apparently having seizures while
all the time.
She is sleeping.
And this is someone that someone may have said, "Can you?" Pelvic thrusting is another.
This is the pelvic thrusting movements which you are seeing. One thing in this patient, the video is a bit slow. However, one thing what happens is the movements increase and decrease
You can see
in speed,
that
which is a fluctuating movement speed, which is again very unusual for a seizure disorder. Rather, it's a PNES episode.
The other one is not so sharp like the first one we saw, and then stops and goes again.
Again decreasing a bit.
Stops and goes again. When in the epilepsy, usually you.
Another example of a PNES patient. The hands are raised, kept in the however, the Right. Tongue biting is a classic symptom of epileptic seizure. However, they can occur in a third or more patients with PNES. The tongue bite occurs on the side, not the tip. And severe tongue biting with lacerations are more specific, but it is again not 100%. Just because you have a tongue bite, we cannot make a diagnosis of epilepsy. It can even occur in patients with syncope. This is the typical area where you get a tongue bite in a patient with seizure disorder on the lateral part of the tongue. Incomplete loss of consciousness suggested by either responsiveness to stimuli or later recall of events again supports PNES. During a 24-hour EEG, overnight EEG, the presence of alpha rhythm, that is the evidence of wakefulness, supports non-epilepticum process. Weeping, stuttering, vocalizations with affective content again are very uncommon in epileptic seizure. So in epilepsy, the vocalization is a guttural utterance. It's by tonic diaphragmatic contraction against a clenched vocal cord. It's almost like the sound you hear from a pressure cooker if you think about it. Same sound that we hear, the stertoral breathing afterwards also there. Auras are very subjective and reliable. Autonomic manifestations again suggest a true seizure. Tachycardia, cyanosis, very difficult to mimic those. The ictus of an epileptic seizure is typically brief, often less than a minute, unless it has gone into a status, while PNES are rarely less than 1 minute and usually much longer. And psychogenic epilepticus is also not a rare phenomenon. PNES is generally supported by a higher seizure frequency than patients with epilepsy. So again, the suspicion is raised when there's a protracted seizure duration or daily convulsive events despite normal examination during history taking. Post-ictal symptoms. As we saw in that first patient, the boy who had a seizure, rapid alerting and reorientation are common after PNES, but very uncommon after epileptic seizure, except in seizures like absence seizures. Respiratory changes with the pattern of deep and prolonged inspiratory expiratory phases, stertorous breathing, which is why I told you that's a very loud snoring breath, like you see in patients who have had a ICH, intracranial hemorrhage. Same sort of breathing pattern will be there in patients who have just had a seizure in the post-ictal period. Patients with PNES have rapid shallow breathing. This is again another example of stenosis. And what you will notice here is the rapid wakefulness following the episode. I think the video has gotten cut short, but she rapidly opens eyes. So this was actually a bit too obvious, but usually following the ictal phase, they may appear to be unconscious, but they can be easily aroused. They may even keep their eyes closed tightly. Key fact to remember is that neurobehavioral manifestations during the post-ictal phase can resemble ictal features of PNES in some patients. So a misdiagnosis can be made if witnesses was not present at the onset of seizure. Thank you.
Thank you, Gerald. Now we can open the floor for questions. So
Yeah, I think
Isuri,
there's a question from Isuri, yes.
there's a question in the chat. The place of serum prolactin in PNES.
Serum prolactin, that is actually, I'm not sure I can answer that. Can you clarify the question? Normally we don't do prolactin for patients with seizure, although I know for a fact that prolactin causes an elevation. Since the diagnosis is so obvious, we don't usually do prolactin in a clinical scenario for seizure patients.
Thank you, sir. Budi Asira has thank you. Thank you for that very informative lecture, John. Okay, so that brings to the end of the second symposium, I think. Thank you very much, John. Thanking our speakers and moderators for that excellent and worthwhile symposium. We have now come to the end of the webinar. I now call forth consultant psychiatrist Dr. Samira Dasanayake to introduce Dr. Uday Samarjeeva, consultant surgeon, District General Hospital, Trincomalee, and the president of the Trincomalee Clinical Society, who is to deliver the vote of thanks.
Thank you, Malisha. It is my pleasure to introduce Dr. Uday Samarjeeva, who has been a consultant general surgeon since 2012, currently president of Trincomalee Clinical Society, secretary of the Association of General Surgeons of Sri Lanka, and secretary of Sri Lanka Association of Minimal Invasive and Digital Surgery. Over to you there.
Thank you, Samira, for introducing me. So I was watching this event, which was actually timely relevant on a topic: addiction, the interplay between psychiatry and medicine. Now, when my colleague Sumudhu told me about the regional event, I was actually delighted because this was an event that was going to happen after a long course because of the current situation in the country. But unfortunately, we couldn't have it as a physical event. But I'm sure by looking at the number of participants and the material which has been discussed so far, that it was actually a successful event. So I would like to first express my gratitude to the President and the Council of the Sri Lankan College of Psychiatrists, especially the President, Dr. Gyan Abhayavardhana, for selecting Trincomalee to have their regional session in this year. And it has been a trend now to enhance the knowledge of the doctors in the periphery so that they would practice on with an up-to-date knowledge. And I also like to thank the speakers representing the Sri Lankan College of Psychiatrists for their wonderful and informative presentations. Dr. Mahesh Rajasuriya, consultant psychiatrist, Dr. Ranila Besingha, consultant psychiatrist, Dr. Kapila Ranasinghe, the consultant psychiatrist, and also Dr. Samira Dasanayake for their excellent presentations. And also from my side, my colleagues, Dr. Devan Yudhishran, my consultant physician, and Dr. Kanchana Ramanayake, our consultant radiologist, and Dr. Dulmini Veeratunga, our neurologist. I think they did their presentations very well and they are very informative. And also, regarding the logistics, especially when it comes to organizing such an event, so providing the help with the logistics, I'd like to thank our director, Dr. Jagat Kamratna, and our regional director of health service, Dr. M. Costa, for providing the logistics service. Now, there are a lot of people behind the screen who actually work hard as a team to bring this event into a successful one. So there are a lot of people, including I'd like to thank, especially the mental health team in District General Hospital, Trincomalee, the doctors and all who work hard to bring this event as a success. and also the other organizing committee, and also the IT personnel, since this is a virtual event. And I beg your pardon if I missed anyone who had worked for this event. So thank you once again. And probably we will wish to have a physical event if the country's situation turns back into normal again. And thank you very much and good night. And please stay safe. Thank you.
Thank you very much, sir. And that's all for today's webinar. It's been a pleasure having you all today. Wish you all a good health and safety during this difficult time. Good night.
you.